good? No, we can't keep down.
No, this is not. I don't know where is she?
Ooh.
No.
She was supposed to go on. She doesn't want her to off her car.
I don't know, my nose is doing pretty good.
I know, I think that's like recording.
It's fine, I was about to go over there and say that.
I can't even
Really
see
helped my
my
anxiety.
eyes.
Yeah, I wish we could just let him run around. He's right here. No, no. I'm sorry. I'm sorry. They're asking his salary. Are you 6'1"?
Yeah, I know. I'm getting the rep ready as well. Just a couple.
With us, so why should talk like that?
You and I sat across from each other at the table and we were like, hey, you want to do your doctorate? Because it was like one of the first conversations I had on this campus.
Put on my glasses so I can see who I'm talking to. Okay, it's so quiet. Welcome, everyone. Fabulous day. It's so nice to see you here. What a wonderful opportunity to celebrate the tremendous accomplishments of the individuals who are going to share their work with us today. I'm so happy to speak for the faculty here at AIC and just congratulate you from the bottom of our hearts on this wonderful accomplishment. We have seen you go through so much in achieving this milestone outcome. And we're just honored to have a chance to hear more about your work and let the people you know who are tuned in today on the live stream or watching you here in public be able to take part in this experience and understand more about the amazing accomplishments you have managed to complete at this time. We look forward to the work that you will do in the future, and we hope that you take many fine memories away from this celebratory moment. So we're going to start off today with Jenna Labadia. She completed a scoping review on the attitudes of stakeholders with regard to sexuality in long-term care. Jenna, want to come up?
Thank you.
Hello, everyone. As Dr. Sullivan mentioned, my name is Jenna Labadia. My capstone is titled Sexuality in Long-Term Care, a scoping review on stakeholder attitudes. Before I begin, I would like to acknowledge a few special people. I'd like to thank the librarians at Shea Library, especially Nancy Little, for all their help and agreeing to meet with me at 7 a.m. I'd like to thank my friends and peers at AIC. It's been an honor and a privilege to work alongside many of you for the last 2 years and most of you for the last 5 years. I'd like to thank my family, my siblings and my grandparents, especially my parents, for all their support over these last long 9 years of higher education. And I'd like to thank my fiance Kyle for all of his love and support. And I'd like to thank my committee members, Dr. Christine Helfrich and Dr. Allison Sullivan, professors here at AIC, for all of their help throughout my Capstone project and throughout the whole program in general. And lastly, I'd like to thank my patients for all of their inspiration and for making work worthwhile every day. First, I would like to give a little bit of background on why I was interested in this topic. In school, we learned that OTs, our scope of practice involves sexual activity, but we never really were taught about how to address it. And as I became a practitioner, I realized how largely it is unaddressed in practice by both therapists and in healthcare in general, and especially unaddressed with older adults. Older adults continue to engage in sexual activities later in life. Expressing their sexuality both physically and emotionally is associated with greater overall well-being, happiness, and life satisfaction. Unfortunately, though, there's still very little known how to support aging adults as they continue to express their sexuality, especially in long-term care facilities. So why occupational therapy? As I mentioned, it's within our scope of practice. The OT practice framework describes sexual activity as an activity of daily living, and the framework describes it as engaging in the broad possibilities for sexual expression and experiences with self or with others. And it gives some examples, such as hugging, kissing, foreplay, masturbation, oral sex, and intercourse. What is a scoping review? For those of you who may not know, it's a type of evidence synthesis where the researcher, which was myself, searches for all available evidence on a certain topic area and then summarizes what's available and what's lacking. It's very common for emerging practice areas where there's not a lot of information known, such as this one, and it can be a precursor to systematic reviews. Long-term care is any facility which provides housing and a variety of services, including both medical and personal care to individuals who are unable to live alone. Here in the Northeast, we think of these as nursing homes, skilled nursing facilities, convalescent homes, things like that. APA defines sexuality as all aspects of sexual behavior, including gender identity, orientation, attitudes, and activity, and it describes the functions much like the OT practice describes them. Intimacy, on the other hand, is described as an extreme state of emotional closeness, and intimacy can either be sexual or non-sexual. It's also important to define attitudes. It's defined by APA as an evaluation of an object, person, group, issue, or concept on a dimension ranging from negative to positive. And our attitudes are often derived from specific beliefs, emotions, and past behaviors associated with these objects. Our attitudes consist of components like cognition, our emotions, and our behaviors. And attitudes towards subject matter often set us up for a process of selective attention. Essentially, what one will learn is determined in part by what one is willing to receive. My research questions are, what are common attitudes of residents, their families, staff, and the public, these are the stakeholders, regarding sexual expression in long-term care facilities? How do these attitudes impact residents' quality of life? What type of research studies are available regarding sexuality in long-term care? And what types of research studies are lacking? For my methods, I used Prisma Analysis Extension for scoping reviews to systematically search the literature. You can see the picture on the right. It just goes through all of the steps, and I'll touch on them briefly. Initially, my search began very broad, My eligibility criteria consisted of studies that were no more than 5 years old. They had to be English, they were peer-reviewed and full text, and they had to focus on sexuality in long-term care. I chose 5 health science databases to ensure a wide breadth of knowledge. And initially, I included search terms such as occupational therapy, sexuality, and long-term care. Unfortunately, my search results didn't yield any studies that met the inclusion criteria. So I instead shifted to a broader overview of sexuality in general, hence a scoping review. My initial search yielded 5,520 articles. After I checked the title and abstract, I was left with 130. After I removed the duplicates, I was left with 92 articles. And after I checked the full text, I was left with 40 articles. These remaining 40 articles were further categorized into 3 themes: interventions and assessments, attitudes, and trainings and policies. My committee and I, we decided to focus on attitudes due to several priorities. As I mentioned, attitudes have a significant impact on learning, so I thought it was essential to look at attitudes prior to looking at training. It also had the largest sample of articles, and it had the highest quality of research. Many of the trainings and policy articles were theoretical or opinion papers. So after completing all these steps, going through the categories and deciding to focus on attitudes, 12 studies were ultimately identified to be included in the scoping review. Of the 12, 10 were qualitative, 1 was mixed methods, and 1 was quantitative. The methods most often used were semi-structured interviews, surveys, or a combination of both. 5 studies mentioned the impact of loneliness, 3 looked at intimacy and sexuality, 2 studies noted the importance of autonomy and privacy, and interestingly enough, every study highlighted the need for staff training or specific policies to be implemented. The first topic, loneliness. When residents and families were asked about intimacy and sexuality, often at the forefront of their concerns was the issue of loneliness. A lot of residents reported social isolation, whether they were heterosexual or LGBTQ+. In addition to the social isolation, however, LGBTQ+ residents reported fear of discrimination too. There was a lot of surveys, focus groups, interviews, things like that. And as I mentioned, the training and policies mostly was theoretical, or like opinion papers, so not a lot of high quality evidence. Thank you.
Thank you.
I was curious if you actually went to long-term care facilities.
I actually work in them
Okay.
right now, so that is another, I've asked a lot of questions about it because as a new practitioner and learning what was going on. I work in a few buildings, so I've talked to different people that I've worked with, my managers, and like, is this going on? Do we have policies for this? And I've heard some like interesting stories. I know Nicole's experienced it too. I don't know if it was in your field work or in practice. In practice. It was in assisted living. So it's definitely, it's going on, and there's not always a lot of policies. There's a lot of like ignoring, or some people are just like, I'm not comfortable, I'm gonna pass it on to someone else. There's a lot of that going on.
Jenna, what do you think the consequences could be of occupational therapists failing to implement policies and guidelines, training around sexuality and long-term care?
Yeah.
Because of the issues you're mentioning, discomfort, the lack of other discipline-specific engagement in the topic.
Right. As occupational therapists, you know, it's within our scope of practice, and if we're not addressing it, why is it within our scope? I feel like as a practitioner, we cover a lot of ground as OTs, as we know, we're very broad. There's implications for the residents. OTs specifically, we have the tools, you know, we have the training on the emotional and the physical ways to support sexuality in general, and we have specific training in older adults and their social emotional needs. So the impact, I feel, you know, we might lose it as part of our identity as OTs, and that's not something that I think is I wouldn't like that to happen, because I think we have specific knowledge as OTs regarding precautions, physical needs, emotional needs. So I think if we're not addressing it.
So for practitioners who are out there who are motivated by this topic and would like to get started, where do you think they should start, knowing that there's very little literature in place now?
There are some continuing educations, and that's something that myself I'm looking into more frequently, and just learning how to start. Being familiar with it is the first step, really. Knowing that it's going on, that it is happening, that it's existing, that's kind of the first step to knowing how to help. The PLICIT model is a great model to look at. It's very basic, and it shows entry-level practice to more skilled practice. So the PLICIT model is a really good model to look at if you're looking for more information. I also have some resources if anyone wants them. Do you have another question?
Yeah, I was curious also about the role of nursing, and if you came across that as this is their territory.
Yeah,
is it territory?
I did see a lot with nursing. I think nursing is one big piece of the puzzle. I think with anything, it's important to have interdisciplinary, because everyone has specific needs. With sexuality, medication is a big, important thing, because if you are dealing with erectile dysfunction or things like that, medication is going to be really important. Whereas occupational therapy, we might help with positioning for, if someone has cardiac precautions and they need energy conservation techniques, or they've had a hip fracture and they can't be in certain positions. We have more knowledge of those sort of things. So I did see a few studies where they were saying, like, this is nursing, but they didn't really go into exactly the details why. And I think as OTs, of course I'm biased, but I think as OTs we have a broader width of knowledge, whereas nursing, it's like one part of the puzzle. Dr. Helmich.
I think it's interesting that this is one of the issues, that it's not who wants to keep the territory, it's who wants to get stuck in the territory. And that in my experience in long-term care or even in inpatient, it was always which discipline is going to have to deal with this, because nobody wants to do it.
Yeah, that was a concern at one of my buildings. The social worker was kind of in charge of it at one point, and they just felt like so uncomfortable. So
I had a follow-up question to that, though. In the literature that you looked at, I know you didn't really, you were trying to get through it, but where did you find the most about guidelines, and like in what discipline?
definitely nursing, yeah. I was expecting to find more in like therapy in general, because I know PT also tries to take over this, but there really wasn't much anything at all in physical therapy.
Which is surprising, because they have a specialization in it.
Yeah. Yes.
In an ideal world, what would your next step for research be based off of what you found to kind of fill in those gaps?
Next step for research, that's a good question. As I mentioned, there's not a lot of quantitative studies, so something with more quantitative evidence I think would be more important. We'd need to look at a lot of research. I also would want it to be more focused in the United States. There's a lot going on in like Europe and Australia. There's not a ton of high quality research going on in the US. My studies were international. So that's important. And throughout the whole country, because obviously we know politically our states are all different where we fall on the political spectrum. So I think doing like a nationwide study is very important to get all kinds of feedback and different political views.
Some preferences about that, but also recognize how my students or my clients might have some of these different reverse responses. And if you know me well, you know that I do have a lot of my own personal sensory experience things going on. So that's why I hear people laughing. But transition to today, I work in a very small therapeutic day school. I work with children who have various levels of trauma histories, and that really impacts their ability to engage in not only their school activities, but also their everyday occupations and routines. So I chose a systematic review because I would like to continue with research throughout my career, and I'm early on, so I figured it makes sense to start with peer-reviewed articles that are based in literature that I'm interested in. So to start, I'm just going to share the importance and objective. I will touch on the other pieces as I continue throughout the presentation. But the importance of this review is that occupational therapy practitioners need more formal recognition of their role in treatment teams for children with complex trauma histories and the development of a more standardized methodology approach. And the objective was to provide a current narrative regarding those interventions that incorporate the use of both sensory-based and trauma-informed care approaches to treatment across pediatric practice. Again, I'll touch on the findings and conclusion and relevance a little bit later, but what this article adds is that OT practitioners' skills in addressing the need for safe sensory experiences, paired with their understanding of applying trauma-informed care approaches with their therapeutic use of self, makes them ideal interventionists for this population. So there's a lot of information within these realms of OT practice and in general with allied health professionals. So you see a lot on here, but I just want to give a good little background before we really dig into what I found in my research. So first I'm going to start with just a definition of trauma-informed care by SAMHSA, and that is the 4 R's, which is realization of trauma and how it can affect people, recognizing the signs of trauma, having a system that can respond to trauma, and resisting re-traumatization. There's also another really great definition that I found throughout the research that I think is a little more encompassing and a little easier to understand. So I'm just going to share that with you briefly. Trauma-informed care is a universal, systematic, strengths-based service delivery approach and is rooted in an understanding of responsiveness to the impact of trauma, which emphasizes physical, psychological, and emotional safety, not only for the client, but also for the providers. So I thought that was really important that they point out that it really encompasses all of these pieces and not just for the clients, but it also needs to be for the practitioners providing the interventions as well. Again, there's no standard methodology, and there was a study in the 90s that was provided some pioneering language for trauma-informed care, and that was the ACE study, and that's the Adverse Childhood Experiences study, and those scores are today recognized as a public health crisis because of both short and long-term impacts on child development, but also some chronic conditions that are observed in adults. And a critical piece of the healing process that must be incorporated into treatment teams is that every single member working with these children has to help provide a supportive and nurturing relationship, or else these treatments aren't going to be effective. And then one more really important piece that's not actually OT specific, it's from a very famous neuropsychologist, Dr. Bruce Perry. He is kind of considered a pioneer within trauma research with children, and he explains that extremes of neglect, chaos, distress, and traumatic experiences can lead to a range of neurodevelopmental problems. And so that's kind of what we're seeing now today, and that's what's kind of being looked into more and more. So more OT-specific literature that I found in this review is from Champagne and Stromberg. Facilitating self-organization of individuals' responses to sensory stimuli is really important to creating a positive change. So you need to really make sure you help the individual with self-organization before you move forward. And in that, you also have to establish a positive relationship with that child, because if you don't have a positive relationship, it does not allow for a working environment, and you cannot interact with that child in a safe manner. One more definition that I really would like everyone to understand is sensory integration, and that's the organization of sensations for use. And so that's how our body takes in the information from the environment around us and kind of processes it within themselves. And that's it creates your own experience of what's going on. And so understanding that, as well as air sensory intervention, which is a very common practice approach used in pediatrics, are two important things that were used throughout the literature I found. And understanding Dr. Bruce Perry's information about how the sensory systems respond and how there's also chaos. If there's chaos around, that can alter those responses. And understanding all these approaches that we need to take, we can then come together and say that children may better be able to tolerate their trauma responses if they have the skills to maintain their body regulation and provides them with a greater sense of control over their emotions, behaviors, but also their overall quality of life. So the research question I aimed to answer was, how does a combined use of trauma-informed care and sensory-based approaches support occupational participation for children with complex trauma histories? So the methods I used, you can see the search terms on the board. I used different versions of those, but just for this purpose, I shortened them. I looked at 8 databases. EBSCO and CINAHL were used for full-text, peer-reviewed articles across all allied health professions. And then I used 6 OT-specific journals to see what was out there in OT-specific literature. The inclusion criteria was that it had to be published after 2014 to include the SAMHSA guidelines for trauma-informed care. They needed to include either OTs, OTAs, or level 2 fieldwork students. They had to be in pediatric settings, and they had to use both trauma-informed and sensory-based approaches. So you can see the flow diagram on the right, and from the results, I found only 4 articles that actually met the inclusion criteria. There was moderate risk of bias across these articles, according to AOTA's risk of bias tables within their guidelines for systematic reviews. The age of participants ranged from 3 to 20. I want to point out that it was actually 3 to 18 in most of them. There was just one study embedded in one of the scoping reviews that went up to the age of 20. However, they were within a youth residential treatment setting, so it was still deemed appropriate. There were a lot of different intervention methods listed. Some of the most common were sensory diet, sensory groups, and sensory modalities. A variety of protocols like the SMART model, safe place, and air sensory integration, and then a couple of different assessment approaches were used. And then just a couple other results. I wanted to point out there was only one statistically significant result within the literature, and that was from a retrospective chart review. And it pointed out that 53% of the child sample demonstrated significant correlations between quadrant scores of the sensory profile and at least one behavioral response category. Some other non-significant results included that every article emphasized the role of OT practitioners within a multidisciplinary treatment team for this population. The most common interventions were just mentioned, but they're sensory rooms, sensory modulation equipment, and groups. And finally, the final non-significant result was that sensory strategies help children to develop emotional and self-regulation, as well as promote attachment and increase active participation. And it was interesting because we would hope that this would be active participation in their occupations, but for the most part, throughout this literature, it was actually active participation in therapy to get to their occupations. So some of the discussion findings included that OT practitioners have that educational background and the understanding of both heightened and depressed arousal states that cause abnormal responses to sensory stimuli. We also have the capacity to assess all areas of both sensory processing and sensory integration to see how those responses are. And we can provide interventions at the just right challenge so that it does not overwhelm the child or discourage them. And this helps to create a safe therapeutic environment using that therapeutic use of self. And this supports self and emotional regulation, healthy attachment, and again, healing from trauma. And overall, with that goal, it helps these children to help manage intensive feelings and emotional and physical responses to trauma. Some of the limitations include, again, moderate risk of bias, a lack of research that was published in OT-specific journals. I actually, throughout the 6 journals I looked at, there was only one journal, American Journal of Occupational Therapy, or AJOT, that had 7 articles that came up when I used the search terms, and only 2 of those met the inclusion criteria. The other 5 I searched yielded 0 results, so that was surprising. Another limitation was that including the guidelines of trauma-informed care within the research articles limited the amount of articles that I could actually include in the final review. And I just mentioned there's a lack of discussion around specific occupations that were helped to engage with this type of treatment approach. So that's something that also really limited what I found. You can see Stacy, one of my community members, playing with one of the kids on the swing, and this is just a good example of, being able to have a relationship using that therapeutic use of self to get kids to do things that might be really challenging for them, and it's really playful, so that's really important. Some of the conclusions include that this review supports OT practitioners in addressing self-regulation and safe engagement in occupation through sensory-based interventions using a trauma-informed approach. And although individual interventions demonstrated successful participation, there's still a lack of a standard methodology. And implications for practice. OT practitioner skills in addressing the need for safe sensory experiences paired with their understanding of applying trauma-informed care and therapeutic use of self makes them ideal interventionists to reduce negative lasting impacts of trauma on children's participation of daily occupations. So moving forward, the research agenda that I came up with was that continued research should be conducted on the use of approaches in OT practice within mental health and published within related databases, but this should also be shifted to really focus on children with trauma histories. And it would be really helpful to also compare children who have experienced trauma versus children who have not experienced trauma in that future research as well, because then it could give us some more significant findings. There are some really amazing preliminary results indicating positive impacts of OT interventions and the negative impacts of trauma. So moving forward at looking at this, it would be really helpful, again, to establish our role as OTs more primarily within this area of practice. Reviewing specific approaches while considering altered biophysiological responses in children who have experienced trauma as compared to those who have not would really also just point out that trauma does have a long-term impact, because right now, if people are only looking at children who have trauma, there's no saying that they just have altered sensory responses anyways. And finally, the area that I was really surprised by and that really needs to be focused on moving forward in the research agenda is that the main area of sensory integration and sensory processing that has been most prevalent in the research is sensory modulation, which is that regulatory component. And future research needs to focus on including discrimination and motor-based approaches, because those components have a potential impact on occupational participation. So moving forward, we really do need to work on the discrimination and the motor-based parts, because that's a distinct value of OT within a multidisciplinary team. Okay, and then briefly, I'm just going to share with you about my educational component. I completed a trauma-informed care training for the Arthur C. Left Children's Burn Camp. This is a camp that I volunteer with, actually, and I've been volunteering with since 2017. This camp is specifically for child burn survivors between the ages of 8 and 18. It was founded by the Connecticut Burns Care Foundation. All children attend free of charge from in-kind donations and fundraising events collected by that Connecticut Burns Care Foundation. And children come from all over the world, from various socioeconomic, religious, cultural, ethnic backgrounds. But one thing they do have in common other than their burns is that in their own communities, they're often stigmatized for their physical appearances because of those burns. So when they come to camp, it's really amazing because this stigma is removed. They're surrounded by many other children and often adults who are coming from areas with similar stories, who also get stigmatized in their own communities. So it's just like a really wonderful place where they just get to be a kid, sometimes for the first time. So the trauma-informed care approach is really helpful in this type of setting, because one of the objectives of the camp is to include enriching and empowering children while creating positive, lasting memories. So if you think about what they went through in their lives, some of them extremely significant incidences, they may not have some very positive memories throughout their lifetime. So providing the staff with a training on trauma-informed care and being able to understand more specifically what these children might be going through, especially throughout this week where they're exposed to so many different new activities and new people and the environment because they're outdoors. It would be really helpful to be able to help them move through these experiences and if they have any trauma responses to better understand why that's happening. I'll just share a couple of things on the screen. So on the left, you see the kids are the superheroes of burn camp. That's actually on the nursing cabin door. So every time they have to go take either meds or get like a burn covered or any kind of wounds that they get taken care of, that's something they see. That's something we say all week because they just are. The middle is our version of a color run. It's kind of fun. The kids decorate their shirts however they would like to, and then they get to throw powder at each other, and it looks like they tie-dyed their shirts. The top right's a lean-to. That's actually the lean-to I typically stay in. It's nice. We have electricity, but one side is open to the elements, so that's fun. And there's usually 4 or 5 of those surrounding a campfire. And it's really important also to keep that in mind that every site has a campfire, and some of these children were burned by fire, so that's like one of those very prominent areas where we need to be mindful and keep the trauma-informed care approach in mind. And then the bottom right, you can just see a bunch of kayaks from a senior excursion out to in islands where they go and have a full day of just a barbecue, and they play games, and they just bond and interact and like braid each other's hair, literally. So it's a nice time and really powerful experience for these kids. So helping in any way I can is really just makes me feel that much better about it. These are the references from my review. And before I close, I just want to say a very special thank you first to my committee members, Dr. Allison Sullivan, Dr. Tina Champagne, and Stacy Sklut, to Dr. Helfrich, and the other professors who helped me get through not only the doctoral program, but also the master's program recently as well. My family and friends, Sean, who have just really supported me the whole time. It's been a long road, as Jenna said, a whole lot of years, so I'm just very grateful to be at the end of it. And with that, I'll close. Are there any questions? Jenna?
You mentioned the fire at the burn camp.
Mhm.
Can you give an example of how you would demonstrate trauma-informed care regarding like the fire pit?
Yeah, so the one tricky thing from my personal experience of not only camp but also trauma-informed care is that it's not like every time you can do the same thing. But I did actually, one of my years in the senior girls camp, so this is a group of girls who had been there for anywhere from like 3 to like 10 years in attendance. One of the girls I was sitting with, and I think I was braiding her hair because she'd never had a French braid, and she was like, oh, I would really love a s'mores. And I was like, okay, let's go make roasted marshmallow. And she was like, I'm not going any closer. And mind you, we're 15 feet away from the fire. So I was like, oh, how do you want to go about this? Do you want me to make one for you? What do you want to happen? And she just then took a moment to say, I'm really terrified of the fire. That's how I was burned. I don't feel comfortable yet addressing it, and so I'd really prefer if you just make the marshmallow for me, and I will do the rest on my own. And it was one of those moments where like I had thought nothing of it because everyone seemed so comfortable while they were sitting around there, even if they were a little further away. But then after that, we I roasted the marshmallow. She makes her s'mores. She's all happy, everything. But I did take a moment to then point it out to her other staff that were around, just to be like, hey, don't ask her to go like tend the fire. Don't ask anything more if she's not moving closer. Just let her stay at the edge of the group. It's just kind of being mindful, letting other adults know to make sure it's appropriate, and not also pointing it out more in front of peers if they're not comfortable. If they're pulling you aside, don't then start talking about it in front of their peers, because some of their peers may not understand. They may have moved on and been like, it's nothing, you're fine. And in their world, it's not fine. So it's just really understanding that happy medium, or finding that really nice balance between what's okay and what's not. Yeah, Lois?
I was curious if the literature is differentiated between 0 to 3, 0 to 5, and then elementary school versus high school.
There is some differentiation. A lot of the settings some of the articles did differentiate within, saying like they use specific assessments for this age group because that's what this assessment's appropriate for versus the older kids. Most of the settings are all-inclusive. They would just say the range. And if there were differences in the results of the different ages, then they would report on it. But in general, a lot of them are all-inclusive.
Tori, you mentioned that children with trauma history may experience difficulties with discrimination.
Mm-hmm.
I think when you're using the term discrimination, people might understand that differently. Can you give an example of the kinds of difficulties that someone who has issues with that might look like? What kind of ways that shows up?
Sure. It's not necessarily what I focused on in my research, so I'm kind of going off the cuff on that. But it's more kind of, there might be a sensory experience in the environment, like they might be touching something, and it might be really hot, but they actually don't notice that it's hot, so their discrimination of their tactile sensation is poor. Or, I see this every week. We have sensory jam, and a kid will fall on the mat, and it just feels like a heavy probe moment, and they think they're injured. So they lay on the mat, and they're thinking, oh, my ankles hurt, but really they were surprised by the fall, and so their interoception is really poor. So it can be very different across the board, but those are just a couple of examples. Yeah.
So seemingly by your research, it seemed like you were surprised in how little you found, and I think probably based off of your experience of working with trauma on a daily basis.
Mm-hmm.
So is it your opinion that you think that this is something that we'll see a lot more of in terms of using sensory approaches for trauma-informed population?
I do, yes. I think that it is definitely a focus moving forward, especially now that more disciplines are understanding it as well. I think we have to be really careful because, as I mentioned, all of the research is really focused on modulation, and that's fine. But there are treatment settings that are starting to focus on modulation within multidisciplinary teams, and the OTs are teaching a doctor or a nurse or a PT how to do those approaches, and then they're like, all right, go ahead, this is yours now, and it kind of takes it away from us. So I think that moving forward in the research, it'll be nice to see more of it coming in, but we do have to be careful who is doing it and who we are teaching and saying, like, you can do this now, because then we're going to lose our distinctive value.
You also said that they only have 7 articles in the OT journals.
Yeah.
Where did you find those?
Synona stuff. Wait, what was that?
Well, where were the others published? No, they weren't published in OT journals. What kind of journals?
A lot of mental health journals. I think that there are a bunch in, a lot of psychiatric ones, some nursing. It was kind of across the board, a lot of mental health journals, so.
Written by OTs.
Some, yeah.
Have you thought about pushback at all? I know, there are a lot of OTs out there that are very invested in sensory approaches to treatment, behavioral management strategies, and if they have research that already shows that these standalone interventions can be successful without mindfully incorporating trauma-informed care, what's your strategy for addressing someone's needs? If this works anyways, we don't need to do that.
Sure. First, I'd probably challenge them to go back and try again and then do a qualitative component and ask how the experience was for the actual participants. And then I'd also just wonder about why they're so confident in it, and why, if it does keep working, what are the long-term impacts? Maybe do a long-term study and follow up with those people, see how their experiences are going long-term.
Thank you.
Yeah. Any other questions?
Thank you. in a different direction, Marcel developed a job proposal, and her proposal was specific for a community-based program that serves in part pregnant adolescent women experiencing homelessness and mental health disorders. So, Marcel, take it away. Thank you.
Hello. So the purpose of my proposal was to present evidence-based material to implement the role of an occupational therapist, specifically in a mental health-based setting. So I used to work for an organization called CGE, which is a nonprofit organization with support housing program for young adolescents who are homeless in foster care, abused, or state appointed. The role of an OT can foresee additional help and opportunities for research to enhance occupational therapy services with the Center for CGE. Evidence has shown the benefit of mental health programs with an occupational therapist reducing psychiatric symptoms while increasing hopefulness and quality for, I can't see the bottom, for quality of life. So during the process, I was a residential associate for the year 2020-2021. So I thought it was interesting that they didn't have an occupational therapist position. They had different roles of social worker or mental health counselor, but they didn't have an OT. So I thought that was very interesting because the young adolescent women, they were pregnant. They focused on ADLs along with their infants, feeding, bathing, toileting. So we kind of had to train them and support them for the help that they needed. So the components of creating the job proposal included finding background information of CGE, the statistics, the vision statement, mission statement, services provided, job opportunities, and the board of trustee members. It included finding evidence-based research on the role of OT in the mental health setting and the community-based setting, evidence-based research on the young adolescent pregnant woman, homelessness, infants and substance abuse, occupational therapy interventions, and then I interviewed an occupational therapist in mental health in New Jersey. So CGE was established in 1998 and it revamped in 2008 with the developmental of new programs. So a lot of the programs included adult residential, substance abuse, child developmental services, outpatient services, doula supports, and supportive housing. So this proposal will aim to break the generational cycle of abuse, homelessness, and substance. The focus population that my proposal was to homeless, pregnant, and parenting adolescents. The adolescent program itself is licensed by the Department of New Jersey, Department of Children and Services, and the Division of Mental Health and Addiction. So they had program services including counseling, life skills development, parents and skill building, psychopharmacological treatment management, health education and academic and vocational training. The most common diagnoses of the population include anxiety, postpartum depression, general depression, and trauma. So here are some statistics that I found on the young adolescent population and the mental health population. So 30 to 60% of individuals who were homeless present with psychiatric disabilities. According to SAMHSA, approximately 30% of people experiencing homelessness were under the age of 24 years old. In Somerset, New Jersey, that's where the program is located, 7% of the individuals are homeless, while 64% of the population receiving services are white and 19% are Black. 1% of the women are also pregnant, as well as 36% of the individuals actually receive treatment from self-referrals. Females that are living in homelessness also have a history of abuse and violence, and they're correlated with having a higher incidence of trauma. Adolescent pregnancies are commonly driven by poverty, and the most common ages that the adolescents that I saw became pregnant were ages 15 through 19. So the current program staffing pattern did not include the role of an OT. Adding an OT position to CGE population will increase the type and quality of interventions currently implemented by non-OTs. CGE's programming aligned with these interventions and improved health, wellness, and being client-centered. So the role of an occupational therapist in CGE is to provide individualized assessment and treatment of specific client functional challenges resulting from the behavioral health disorders. The assessment and treatment will follow reimbursement guidelines established for behavioral health services and provider guidelines. So services by the OT usually are typically billed to be reimbursed through the New Jersey Medicaid. The CGE OT will provide consultation, evaluation, screening, and assessments to function at the maximal capacity. The OT is there to create a safe place to provide transformational behavioral health, substance abuse, and mental treatment to women, children, and the facilities affected by the abusive trauma. Additional roles will include the clients being screened for medical disorders, depression, eating, sleeping disorders, and their infants are also referred for appropriate interventions. Their children are assessed for development and meeting the developmental milestones in order to assess family resiliency factors. The CGE OT will create and co-create with other professionals, such as mental health, counselors, social workers, the program director, program policy and guidelines to improve outcomes and make recommendations to the program and clients. So there's a lot of interventions that I found through evidence-based for infants and for adolescents. For infants, it was mother-infant play. The OT will observe and assess the play-style interactions between the adolescents and their children. They will help the adolescent interpret and analyze positive and negative outcomes of mother-child interactions and problem solve to create new outcomes as needed. Their infant breastfeeding and infant bottle feeding. The OT will assist mothers to form new routines and habits to promote smooth training, as well as help with feeding difficulties. And the OTs will educate the mothers on the role of infant reflexes, such as rooting, sucking, and understanding differential food intake to proper infant nutrition. For developmental milestones, the OT will track infant development progression and assess the sensory capabilities of infants within their first year. Now with the adolescent interventions, they use a lot of coping skills, self-regulation, fabricating a sensory environment, such as olfactory, which is smell and tactile stimulation using stress balls. I know at the facility they did have a Zen room that had like different strobe lights, putty, things for them to sit down with their infants. Stress management, use of expressional activities such as writing, freeform art, sculpture, painting, to practice self-control. Some of the adolescents did have substance abuse, so using combinations of psychosocial or pharmaceutical approaches. Trauma-informed care, anticipating and avoiding institutional processes and individual practices that are likely to re-traumatize individuals. So that includes us having and making a safe environment and promoting safe resources through creative writing and emotion regulation. The Wellness Recovery Action Plan, such as the RAP plan, is a plan self-directed between the client and OT to identify steps to take during a mental health crisis. The plan is created to find triggers and provide daily maintenance. There's also role playing, which is used to help problem solve the adolescent's basic needs, such as maybe opening a bank account or participating in mock interviews for job interviews. And employment and education, the OT will assist with identifying and selecting work opportunities consistent with the limitation goals and interests. So there are also life skill interventions, and the life skill interventions can be individually with each adolescent or in groups, and the participation can create social networks and consistent daily routines to decrease the traumatic symptoms. So there's what is called the Life Skills Manual. It's a manualized evidence-based curriculum developed between 2009 and 2012 by Dr. Christine Helfrich, ready, available for adults or adolescents who are interested in learning practical life skills. So the different group sessions will include food and nutrition, money management, home, and self-care, and then safe community participation. Evidence-based research has shown that OT life skills interventions can create social networks and are consistent with daily routines, and they can decrease the impact of traumatic symptoms. An article authored by Dr. Helfrich with the homeless youth, domestic violence victims, and adults with mental illness implemented the life skills interventions to optimize their independence, housing, and use of their skills. So the module is based on the model of human occupation, which we know as the MOHO model. And it's a holistic approach looking at the individual. It explains how occupations are motivated and organized into daily life patterns and perform within a person's environment. So in this article, the life skills module model was implemented for ages 14 to 21 in an emergency housing. So the timeline of the stay that the adolescent stayed was 3 to 4 months. Each module lasted about 60 minutes for group sessions and 60 minutes for individual sessions. In conclusion, for the results, the life skill interventions with the homeless youth, domestic violence victims, and adults with mental illness may indicate that individuals may have shown increased accuracy and one's self-appraisal skills from learning what one does and does not know. So these were the 4 modules that I was talking about previously. So the food and nutrition module focuses on activities that learn strategies for healthy meals, snacks, enforcing budget for food, identifying food sources in the community, money management, saving money and budgeting, home and self-care, increased knowledge of ADLs, activities of daily living such as self-care, hygiene, clothing management, and improving physical appearance and environment. Safe community participation, learning how to handle emergencies in the community, and discussing home, community, and personal safety. So this is a logic model that I created as a visual if I were to propose this position. It talks about like what I explained before, like not having an OT position, the focus, us requiring a master's or doctorate level, us including the courses that we have taken in the past, the consultation, evaluation, and assessments, the treatments that I spoke about, so mother-infant play, life skills interventions. The short-term goals will focus on identifying the life skills to use in natural environments, such as the laundromat or going grocery shopping, making recommendations to other professionals for support. And then the overall long-term goals I'll talk about later is possibly having students in the facility, in the community-based facility, to extend for the program evaluation research or decrease the reentry of adolescents with community support services. So these are the different assessments and screenings that I found through my research. For the pregnant and parents and adolescents, the Canadian Occupational Performance Measure, the Allen Cognitive Level, Coleman, Ansel, Cassie Life Skill Assessment, the Model Human Occupational Therapy Screening Tool, and the Executive Functional Performance Test. For infants, they were similar, except the NEO-EAT Mixed Feeding Assessment Tool, the Pediatric Eating Assessment Tool, the Child Oral Motor Proficiency Scale, and then the Toddler Sensory Profile Tool. So for program opportunities, I thought that expanding the role of OT and CGE will provide more comprehensive recovery services to some of the county's most vulnerable citizens, which is the homeless adolescent population. Expanding on reimbursement services provided by CGE. Generating increased revenues for the organization via consultations or referrals and assessments. So Rutgers University in New Jersey is about 45 minutes from that organization. So I thought it would be a good idea to partner with them because they do have a social work program that assists with substance abuse treatments, and then potentially having fieldwork students provide extended or additional programming for no cost for further opportunity of research with collaboration with the Rutgers University students. So for cost effectiveness, billing, and reimbursement, there was limited information regarding specific criteria to maximizing cost effectiveness and productivity in the position of an OT. The OT services are seen to be cost effective and improve productivity as demonstrated by evidence-based research, but this area still requires further clarification. Reimbursement for services may initially be challenging due to insurance adjusters not being familiar with the reimbursement for OT and mental health. So these are my references, and before I end, I wanted to extend a big thank you to my committee members, Dr. Helfrich and Dr. Sullivan. It's been a long journey. And then my family and my friends that supported me through this program, as well as Dr. Margaret Swarbeck, she's an occupational therapist in mental health, but she's also a professor in substance abuse at Rutgers University that I got some of my information from. Thank you. Yes, Lori.
How likely are you to propose the role?
Highly likely, because I do still have connections to the program. Like even though I don't work there anymore, they knew that I was an occupational therapy student at the time, and I was passing my boards, and I still do have contact with the program director. And she was kind of open to the idea of possibly like observing and being a volunteer. I feel like that's the first step in, and then I'll see what happens. But I think I have to tighten up my proposal to start that. Both.
So I was just curious how much information they have in 0 to 3, the 0 to 3 organization, where they're trying to stop repeating the cycle of poverty, violence, drugs, etc. And so they're, their infant mental health programs for working with the moms and working with young moms, etc. So I was just curious if you were aware of the organization, and then if they have any programming that speaks to that.
For this organization or others? As a residential associate, no, that's something that I would have to look into, because I know their programs were specifically with like the social worker or with the psychiatric mentor, but I would have to look into that. Yes?
Well, I would love to talk to you offline about this later, but I do have a question. So back to the assessments, do you think you could use any of those assessments to show outcomes of the adolescents to support reimbursement?
That's a good question. I didn't find much information on reimbursement, possibly maybe like a pre-test and a post-test, but I feel like that's something I would have to either interview an occupational therapist or something I would have to find out on my own. I did see some like outcomes that were with the Ansel Cassie life skills intervention. I did see an improvement, but I think I would still have to find out more information to see how effective it would be with any of those assessments.
I think it might benefit you if you looked at the mother-infant as a dyad, because there is prior knowledge that that connection leads to improved childhood outcomes. So maybe that might be a good place to start.
Okay, thank you.
Marcel, I was wondering if, it's my understanding that many young women in this situation wind up having to release custody of their children to the state. So is there a role then with regard to the interventions around grieving and how that loss of the child as a primary custodian affects their role as a mother and obviously, self-esteem and that sort of thing?
With the current role at OT? I didn't see any. That's a good point, but I'm sure there should be for emotional support. Because I do know when I was there, a lot of them did get, even though their children did get taken away, they were looking to get them back, and they did have primarily business and stuff. So I think, yeah, there would be an intervention. I'm not sure what the interventions would be, but that's something I'd definitely look into.
So going back to your presentation, you may have answered it already with the state program and losing sometimes the adolescent teens who lose their children to the state. Do the states offer any incentives to even trying to put in a program or a liaison or a point of somebody to reference for that?
Yeah.
Is affiliated?
Yeah, so usually the DCF worker will come to the facility and promote them to, they'll watch and see how they observe their kids, and they'll make points, and then they go through the court system. But as far as the staff, we step back from that. It's usually like a caseworker that they have appointed to their specific infant, and they try for the most part to get them back together, but it takes time, because a lot of these young adolescent pregnant women, sometimes they have like substance abuse or domestic violence or some type of issue that needs to be resolved, and that's why they're in that treatment program for so long. So I think the caseworker just steps in and tries to make sure for them to be back with their family that it's the most safest environment, and they're getting the tools provided at that specific facility.
wondering if you could elaborate more on how you plan to share your work and how it might be a good guidance for other OTs who are searching for unconventional roles in the community setting.
I haven't really thought about expanding that far yet, just because.
Well, maybe you could talk about what you're planning on doing with this proposal in terms of talking to the director.
Oh yeah, so we can start with that. Yes.
Dr. Swarba through Rutgers, and you've got a lot of plans.
Yes. My next step, since I already talked to the program director and I already interviewed Dr. Swarbeck, she told me she wants me to follow up with her on this position, and she's also friends with the program director, so she wants to get involved and propose this position to the board of trustee members. And then once I get through that, they would have to figure out if they would want me in the program itself. Because they already consulted with an OT previously they have a training called the Nurture Approach, which is mandatory for staff members there, that was created by an occupational therapist. So I feel like they would be more open to, because there were programs or trainings created by OT initially. So I feel like it's something that they would be interested in, but it's more so me, I guess, proposing the idea and them wanting, I guess, them to accept me into it. I think it's kind of an in for me because I've worked there in the past and I have that repetition or just that support with the program, so that's the initial.
And then I think because the position doesn't exist, do you have some ideas about the open position they have and convincing them about, or suggesting to them how to fund you? Learning position?
Well, yeah, through grants. I guess I would have to write up a grant proposal for them to get me a position to open up, but they do have positions open for mental health counselors, but I would just have to let them know how an occupational therapist would benefit them specific to their program.
Kind of the added value of an OT.
Okay, so another question I have is, I know there was a need for this particular type of OT in that type of setting. Besides the need, were there any challenges that you faced working in that work environment that kind of helped you or see it in a different way that did push you to look at it differently?
Yeah, I did run a lot of life skill groups. I noticed that they did not know about budgeting, credit cards, debit cards, just like things that we would do, like going to the grocery store or car loans. They didn't know anything about that. So a lot of the times I feel like that was something that they need to be educated on. Most of them were like 16, 17, 18. So I feel like those are things that you need, especially if you have children, and they're not going to be placed at this place forever. So eventually they'll need to learn these life skills outside. So those are the things I saw. A lot of them weren't really aware of, these things that they need outside of the facility, because the facility did everything for them. They didn't really do anything for themselves. The facility provided the food stamps, gave them the allowance every week. It's just up to them to follow through when they leave. Yes.
Hi, Michelle.
Hi.
I just want to say congratulations, and I also want to just say that I think you should be really proud. I think the work that you've done, you've got a really good foundation here to really, and you've done a nice job to show where OT really could have a place here. So I think that, don't sell yourself short as I'm sitting listening. I think you're onto something. I think this could be a really great program, and I applaud you for working on it.
Thank you.
Woo!
Okay, so happily enough, I think we're a little bit ahead of schedule today, and I'd like to suggest that we break now for coffee and a little snack outside, and then we'll come back for the 2:30 presentation.
We said, I got in and we were talking at the car, yeah, because we're both coming, right? We got out of the car and.
My advisor throughout the whole year.
I know, I was so excited, they're like, you know, just great as always, and how's it going?
And my aunts and family are very supportive.
Yeah. The aerial view. That's what they have.
And how they work in
You need anything, yeah, train, advice, or if you want to do, or if you want to try to do public, anything, help me with that. Where?
It's in Maryland.
Okay, good. Great stuff, you'll be good at it, you'll be good at it. Yep. I'm so proud of you, that's awesome.
She told me it was 5 hours. So when I called her, she was like, they were like, what is that? It takes around 10. You know, yes. So I think for 10
There's a bunch of them.
Just
I know that there's cookies and there is a place next door that's one. No, feel free. Big thing, I don't have to do that myself.
Yeah, that's true.
Yeah, because
I have been this year, but it's still like 35 years. But there's no point. It doesn't say like you're over 20.
So what are all your
Full and clothes. Oh yeah. And I only included one in that. I didn't use the if I used like and then I put the other piece.
I would think that that's much more. Because if you're having extra, because that's always information.
Bianca's dog, my just crying, so I was just giving him a little bubble. We had him moving around downstairs. Did you?
Oh, what a cutie.
Oh my. Bianca tried to send him home, and I was like, please don't take that away from me. And I know he said I wanted to. Bianca was gonna come to love Terry family, and I was like,
Like, I'm not
keep
on
him here.
Thursday, and I usually
He just
like,
wants love.
So well behaved.
On to the next one.
And that's how big he's gonna get.
What do you guys
That's it. That's it. And a shirt poodle. I thought it was just a baby. I don't think so. We've all been playing with him for a while.
Well, I saw the bag tossed, like passed around. I'm like, how's it going? Look at this high-tech setup, huh?
I know.
I'm gonna have everybody being able to watch, so.
Oh, just Where'd she go? She's gonna be right down. Yeah. This is like a poodle, huh?
Miniature poodle.
I know.
She said he doesn't fight at all.
I screwed the whole thing up. I screwed the whole thing up.
No, he's
I
not
took him out.
What's his name?
I
don't want to get you riled up and excited. You're shaking. Don't pee on her.
No, they wouldn't do that while they're holding them. Would they do that while
Some
you're
little
holding them?
dogs do when they get excited.
Oh, really?
I don't think-
What am I gonna do now?
He hasn't yet, but.
Do I put him back in? Oh, God.
Is she gonna get upset? that
No,
he's, like,
no.
getting- oh.
Okay, let's get him.
Because sometimes, like, my parents just got a new puppy, and like, our kids go up to them when she's asleep.
This is so sad. I know. Oh my God. I'm like gonna get in big trouble. Okay,
You know,
okay.
she's not have her nap, and she doesn't have her nap, and she turns into like terror puppy.
Purposely like.
Oh, no.
My cat.
No.
It was still wake up at like.
Okay, guys, I cannot put this dog in here. I can't do it.
Just let him carry him.
Yeah, well, he'll be alright.
They're better on the floor than you. We're blaming you.
She did it.
It's like we set a precedence that he can play.
That's okay, we can miss her. She won't be in it.
I need to take it.
He's gonna go to the bathroom in here. He's gonna go, I can help.
I don't know why this
Should I bring him
dress is
outside?
so comfy.
You think he's gonna pee?
I don't know.
I was walking over here like, and it's like this. I like,
I'm gonna let it go.
It looks like a rocker.
Ready?
Wait,
You want me to take it?
No.
Okay, I'll bring him back.
Do you want me to speak it?
He's not gonna stay.
I know, that's what I said. She was saying that to ramp him up.
Oh,
To other people.
She said that. Okay, all right.
Come here. Because he gets excited.
Come
about
here.
people, So she was trying not to draw attention.
Oh, well, I screwed up.
It's okay.
Come here. Look, you two toy. How does she get him in the back?
She uses her mindfulness stress reduction to calm him down.
She had no problem getting.
She did so good.
Okay, let's go this way. Let's close the top.
I want them to do this. Yeah, no, it's right here. Maybe on left there on the right. Somebody left their like Crocs and stuff in there.
Oh, Bianca had Crocs, you could her.
Oh, okay, because Tori's mom was like, is the bag in here? I was like, no.
How's everything going at AAC? It's weird that it's been so long since we've been back, but it feels
Oh,
like
you
just yesterday.
know, the huge. Crisis mode. Dr. Fry is super sick. He was supposed to give the pinning speech. That we all like kind of passed the torch.
Are we supposed to be busy?
So it's like scrambling.
I didn't bring my stuff. No.
It's in my car, but.
No, I thought.
No, it was last year. They like melded the two ceremonies because they weren't doing an official graduation, so they made pinning more of a pudding and like graduation ceremony. But it's strictly that, and then tomorrow is your day.
I wasn't sure if we were actually doing a pudding. That's all.
Oh my god, how excited is Kate gonna be back in her pockets?
I know.
Oh, you got it.
So when is the next one going?
Probably two. It's supposed to be
2:30?
two.
Oh, 2:30 or 2?
Yeah, two.
Yeah, she
So
said
we
just
had
a
10
10-minute
minutes.
break.
We had that 10 minutes in the school.
She didn't put him up there all the time.
Well, you nailed it, Jenna. So professional, so prepared.
did. Looked up the whole time.
Yeah.
Thanks. It's really good.
Yeah, the email she sent said 2 to 2:30.
Oh, really?
I don't have all the sandwich in here. You want it?
Maybe it is then.
Well, I was gonna be all official afterwards, but it was
Oh, thank
just.
you.
I got it, so it's real.
Thank you.
So like,
I'm
really
excited.
blew us away at
I'm
that.
excited
So like
start.
words of encouragement, given the position that I'm in and don't have anything published exactly a year later, is have your moment to woosah
Yeah.
and be like, I'm done, this is over, it's completed, but then dive right into it. Over the summer, you're a school-based
Right.
therapist.
Yes.
Use your summer
Yes.
to actually look at it, because it's so easy
Yes.
to put it aside and just be like, oh, it's pretty much done, or I could do this or that.
Yeah.
Because Kate, being on my committee, she's like, Courtney, she's a bug in my ear every month. You're 97% of the way done, just submit it, just do it. And
Yeah.
I'm like, right, yeah. So it's very easy to just.
Well, I think too with the deadline, I guess, for the fall semester, like with that collaboration with North Carolina High, like I already have that set, so I know I have to prepare for that. So, making sure all that's
AOTA.
AOTA.
June 2nd.
Yes.
If you just get a poster out of it,
Right.
at least it's a poster.
Yes.
And it's submitted as
I know one of our assignments was to do like that proposal, and I
well, then you get an HR abstract.
Yeah.
That's
yeah, for sure.
So, just saying. Yeah, because there's us, right? We're just, life and work happens.
Well, yeah, having kids. Yeah, I was like, there's no way I could have done this without kids. I'm like, I need to get out of it.
Yeah,
When are
that's
you getting
true.
married?
We haven't set a date yet because we got engaged in October and I started looking at, thank you. I started looking at places and then I was just like, I can't deal with this right now.
Yeah, no, it's.
I was like, I just can't.
I know, I don't know how Nicole did all of the wedding planning and.
She got married, right?
Right?
Yeah.
Like,
Do you
last
remember
month,
me
right?
like attending
No, she got
Zoom
married in
classes
the
here
fall.
up? Like I'm like, I'm sorry everybody, I'm breastfeeding.
How long ago?
It was crazy. 20, fall of 2020, so the fall semester before we graduated in 2021, I took an incomplete in policy.
Which you should not have done,
Which I
because you
should
did not
have
listen to
done.
me.
So did you have to go another?
No, I just did all of the work over Christmas break
Okay, that makes sense.
and submitted it, and
Because they
then.
did give us a lot of time, like 4 weeks or something. I was like, oh, I'm going to start
They
my Capstone, I didn't do anything, and I was scrambling for the
They
beginning of the semester.
restructured too, for us, I believe, the way they
The
did
order of
the
the courses.
research courses were in the summer, like summer session 1 and summer session 2.
That's what
were
we
two
wanted,
research
do you remember?
courses.
So that's taking feedback from us. Yeah, because we all said that we would have liked to
Just so
start
there's a nice
early.
continuation.
Yeah,
You're already kind of almost there, and
Right,
then you
and
can
then
start your
just
survey
keep
sooner
going.
and
Yeah.
be ready.
but it is condensed too, so I think,
That was hard.
yeah,
too.
that was hard, like, for them to structure. But I think it worked out fine for us.
I liked it that way this summer. I didn't feel like we got killed in the summer.
No, I think it was a good course for.
So then what'd you have in the fall? Did you have one course or two?
Did you
We
have
had
policy still then in the fall?
We had
We had ethics and
community base.
Oh, they bumped community-based.
See, I liked having community-based
It was
over the
better
summer.
in summer, it was easier access to go look at things. And
Yeah.
yeah, that was the hard part. It was like between ethics, trying to like, get in touch with.
Yes,
people.
I don't
And
think
community-based
that was
having to
the
do a needs
best.
assessment.
Yeah, I don't think that was the
That was
best courses
hard.
to pair together.
Yeah.
Because it was a lot of like
Reaching
dates
out.
and reaching out and scheduling.
And
like,
being on top of
interviews
your-
and-
Because
Right,
if you save anything, like last minute,
Yeah.
you're scrambling
Yeah.
with other people's deadlines.
Right,
Because it's
exactly.
contingent upon other people, not just you getting it.
Yeah.
yes.
If this goes till 2:30, I should have gotten this now.
Yeah, I think
Are you
so.
sure
I
you
think
don't
it's
want this
very
much?
It is now.
It's from whatever your Wilbraham place is.
What'd you got?
The market, it's an avocado BLT, like avocado BLT.
That's what I would love right now.
Do you want?
Yeah, they have like
All right, then I'm gonna go across there.
She was trying to do congratulations.
So what, are you now doing this?
Am I doing it?
I don't know who's gonna do it.
oh, this is the thinning thing.
Yeah, because I can't hear
Yeah.
I told Caitlin, I'm like, nothing really sick because he doesn't miss any.
No, and stuff like this he doesn't miss, he loves this stuff.
Yeah.
He got sick really fast.
That's
He was
sad.
in
I
our
was really
office.
looking forward to seeing him.
He was in our office and then.
I haven't met you.
Oh, yeah, I'm Paylin.
Paylin.
Paylin, yeah.
What,
I'm
she's a
working
new
here.
camera coordinator.
Yeah.
Oh,
Awesome.
Yeah, but I'm actually like peers with you guys because I graduate
like, you can string PIP jobs together, but don't give up your dream of living in the city. That is God. I took it out, I was like, live, like, just live, be 20 and be. No, don't do it. Until this, if you're gonna do this, don't be stuck. But if you're not doing this, don't be stuck. That's my But then you're just, you're not really, is it the dog?
Yes.
In the bag. I thought it was her chair at first. I'm like, she's not even moving. I thought your chair was making those noises. No, so I'm looking at your feet. I'm like, she's not doing it. Where's it going?
It's my love. Yeah, he's so quiet when she's sitting right next to her.
Does anybody know where Bianca is?
He just wants love and attention.
Just let him out and run around.
That's what I thought.
He's so square that on your own phone.
But it's not letting me send it. Okay. That's what I do.
This is so good. 8.
So I think here we have 7. Is everybody live or is anyone virtual? So ours, so it was a little bit, because there were two part-timers that went through.
Yeah, we have one part-timer.
Yeah. And so it was really like 6 of us that were like, really felt like over, and then 2 people just kind of like came in.
Yeah, we were here and then we have one more.
We had one that was finishing when we started here. She was up, so when it was in there,
Yeah.
Told you. That's what I was saying about
I'm thinking about.
Yeah, that's what I was talking about when I leave. But I think promotions also taking
Okay, I'll be your backup. If you see like you go to the restaurant, and I already had a call from my mom off on the way over. So good. This is awkward. Oh, so I told her. I said, "Did you back?" She actually tomorrow, but she's. Oh yeah. Kansas City girls, Kansas City.
Oh, yeah. I absolutely love you. And then also some people
Yes, everyone's here. You told me that you're. Lois is here. She's over there.
Okay, everyone. Welcome back, and I'd like to welcome Nicole Newman. She's going to be sharing her systematic review, which involved emergency department sensitivity training for autistic individuals. So, Nicole, you can point up here.
Hi everyone, my name is Nicole Newman and I'm doing my presentation on emergency department sensitivity training for autistic individuals and systematic review. So I want to start off by explaining why I focus on emergency department sensitivity trainings for autistic individuals.
So it all started with my level 2 fieldwork experience working in outpatient pediatrics with autistic individuals. Talking with parents, I realized how truly difficult it is to go to doctor visits or even interact with the community for both autistic individuals and their families. So this made me think, how can we as occupational therapists help? So this is when I started looking into trainings for first responders, and I realized that there were trainings in place for this topic already, and there was more research on those areas. And then I began to think of more of settings where occupational therapists and other healthcare workers may work in. And I noticed that the emergency department was a unique setting because a lot of the times you're seeing that person for the first time, and it may be the only time that you're seeing them. And then being able to switch jobs from adults to pediatrics, I was able to see more of these children and their parents and the difficulties that they interacted with in the community, and being able to figure out ways to help them, and then thinking of how they interact with their community and when they go to the emergency department. And then I wanted to start off by just explaining some of the topics I'm going to be talking about. So autism spectrum disorder, also known as ASD, is a developmental disorder that can impact communication and behavior, and it presents differently in each individual. It's estimated that 1 in 44 children and about 2% of adults in the US have autism spectrum disorder. And autistic individuals may have specific healthcare needs related to ASD or other co-occurring conditions, and they have higher unmet healthcare needs compared to the general population. And they're actually more likely to visit the emergency department than other individuals, and this environment particularly presents with a challenging environment. So the emergency department can be stressful due to sensitivities to sensory stimuli, problems with communication, transitioning between different areas, unfamiliar people and places, and pain or painful procedures. So most of the time you're not going to the emergency department because you're feeling well, it's usually because there's something wrong. And sensitivity training can help improve the knowledge and comfort of healthcare providers in the emergency department in order to provide the interactions between themselves and autistic individuals. However, there are not a lot of studies on this topic, and there is little education provided to healthcare providers about ASD and the characteristics that create challenges between autistic individuals and their healthcare providers. And while doing my research, I wanted to be able to define who the emergency personnel were, and I didn't want to just include like nurses and physicians and therapists, but also the administrative staff, security, lab techs, radiologists, phlebotomists, volunteers, and anyone who interacts with them in that setting. So the moment they walk in and the moment that they leave, whoever interacts with them, I believe should have that training. And then how can OT be involved? OTs work in a variety of settings, and the OT profession is always advancing to meet the needs of our changing society. So being able to change and work in these areas is really important. And in the United States, it's actually not common for OTs to be working in the emergency department as it is in other countries, such as Australia, Canada, or the United Kingdom. And then OT services provided in those areas are actually, there's positive impact noted, as well as reduced hospital admission. And in order for us as OTs to meaningfully provide patient-centered care, we must pursue practice in settings such as the emergency department in the US. And then the need for OT. OTs can be effective in preventing unnecessary and inappropriate admission, assisting staff in deciding a plan of action, and helping to address psychosocial needs by helping to calm patients who are anxious, attempting to make the area calm, therapeutic setting for themselves and their families, and that helps improve the perception regarding the quality of care. And we as OTs have the specific knowledge and skills based on the best available evidence to promote health, establish skills, maintain abilities, and modify barriers to participation. And because of our expertise in activity and environmental analysis, OTs are particularly skilled in using evidence-based strategies to address self-regulation, sensory needs, adaptive skills, mental health, social participation, and daily life skills. And roles of OTs don't just include direct services. They also can include consulting, collaborating with others, and advocating for modifications and accommodations that support community inclusion. And then I feel like a hot topic these days is determining the proper language to use. So there's person first versus identity first. So person first would be identifies that a disability is only a component of a person's identity, not the defining feature. An identity first does not separate a person from their diagnosis and can be used as an expression of positive social identity. And thanks to Dr. Bill Wong, who's one of my committee members, he's also an autism advocate, professor. He's involved in research and an occupational therapist who is diagnosed with autism, for helping provide me with the opportunity to learn from someone with lived experiences. It's been extremely important because a lot of the time I was using person first because I thought that's what we should use. And he actually told me that's not what the autistic community prefers. They actually prefer to be used with identity first, which is autistic individual, compared to individual with autism. So then my research focused on do sensitivity trainings improve interactions between emergency department personnel and autistic individuals. So I did a systematic review and I searched 3 databases, EBSCO, CINAHL, and ProQuest, and I found 5 articles following the screening and eligibility. So this is my flow diagram. So I started off and I found about 5,000 articles after looking through the 3 databases, and actually most of my articles I found were in ProQuest. And after excluding articles for being involved with other departments besides the emergency department and other diagnoses besides autism, I then ended up with 25 articles. And then after reading through them more, I found that we debated with my committee if we were going to involve in those emergency departments, if we were going to include EMT or EMS involvement. And we decided that since they have individual studies on their own, we were going to not, for this study, do that. So we were going to just do emergency department personnel on their own without EMT or EMS involvement. And following the screening and eligibility, I had 5 articles left that I included in my review. And it's important to note too that only 2 out of my 5 articles are based in the United States. So it does show that there is more of this research and OTs in the emergency department in other countries. And I included my articles if they were published in English, the emergency department setting, emergency department personnel, and if they included autistic individuals. And through my results, the studies investigated the experiences of emergency department personnel, autistic individuals, and the families of autistic individuals. And I noted in each article that there were strategies and barriers found, so barriers to care and strategies to help improve care in these settings. So these are the strategies that I found. The main one was the training. So needing more of that training would be a strategy to help improve these interactions with autistic individuals, and being able to add caregiver involvement. If a caregiver is coming with that autistic individual, it's important to talk to them because they're the ones that know them best. They're the ones that see them on a daily basis. But on the other hand, it's also important to note that not all autistic individuals have a caregiver with them. There are adults with autism, so it's important to understand that they may need a different way to adapt to it. So being able to have something, maybe like a hospital passport, something they can bring with them to be able to help us better understand what they need more assistance with, what they have difficulties with. And then environmental modifications, being able to modify that environment, and for us as OTs, helping to assist in that by providing maybe different ways to reduce lighting or different sensory area for them to go to, or even having like a coping or a sensory kit for them to be able to pull out and know what to do with it in those situations. And then for communication strategies, being able to communicate as a team, not only just between the healthcare providers themselves, but also with the caregivers, the autistic individuals, and just figuring out what's best. And then working as a team was a big strategy because teamwork is always the best. And then just being more aware, understanding what autism is, what it looks like, and then we also need to go beyond awareness. We can't stop there. We need to include allyship and advocacy, and if we stop at awareness, it may eventually become just a barrier. And then as you see, the barriers kind of relate to the strategies as well. So the environment was a big barrier because the environment is difficult for these individuals. They have different sensory preferences, and it's just a busy environment. There's a lot of lights, a lot of things going on, and there's sometimes that lack of training. So being able to provide this training is extremely important because sometimes certain individuals that you may assume have training or knowledge may not. So we can't assume that everyone has this training and knowledge, and we need to provide it to everyone. And then communication. Not enough communication in the emergency department has been a barrier. And there's also wait time. So most of the time you go to the emergency department, there's gonna be a long wait time. So we have to figure out ways to help with those wait times and see what we can do if we provide a different area to go to, somewhere that they can be a little bit calmer. And then inadequate knowledge, not having that knowledge that they need to about the autistic individuals and then the characteristics of them as well. So being able to understand that everyone presents differently, so knowing different ways to assist in certain situations. And then one of the biggest barriers too is competing demands. It's such a big area and they have so many things to do, the doctors and the nurses. Sometimes it's hard for them to take a step back and focus on helping these individuals in a situation, so being able to figure out what they can do beforehand to assist with that is important. So for my study, there are some limitations. There was a small number of studies meeting the inclusion criteria. There were no studies including results of actual implementation of the trainings, and there was no discussion at all of who would be creating or implementing the trainings, which is extremely important because these trainings should involve multidisciplinary and as well as autistic individuals because they are the ones that are actually having these lived experiences, so I believe it's extremely important that they're involved as well. And there's also lack of rigor, so we need to establish a basis for increased rigor to develop guidelines. And then for future research, guidelines need to be developed, and there needs to be further research to understand the perceptions and experiences of professionals working with OTs in the emergency department, as well as OTs' perceptions in the emergency department, and even autistic individuals. And then we need studies with increased rigor. So we want to capture authentic voices. We want those lived experiences of autistic individuals in the emergency department. There's no better information than the actual experiences of those autistic individuals. And then we need to advocate for the role of OT in the emergency department. Autistic individuals deserve proper care, and without this care, there could be so many detrimental damages that we need to be able to figure out how to help them when they're in a situation where they need a lot of help. And then implications for practice. OTs have the skills and knowledge to work in the emergency department with autistic individuals. We have strengths demonstrated in therapeutic use of self, addressing sensory needs, and assisting with environmental modifications. And whether it be direct services, consultation, or advocating for changes, OTs must look to assist in making changes in the emergency department. And I feel like sometimes, especially us as new OTs, we like to go into a setting where there's maybe something already set up or there's other OTs. So being able to get out of our comfort zone and go into these areas where there aren't OTs and be able to push in there. And then also looking for the opportunity for OTs to work in the emergency department and demonstrate leadership. So in conclusion, my review demonstrates the need for further research to be completed in this area with increased rigor, increased points of comparison, and the involvement of autistic individuals in order to capture authentic voices of the autistic community. And I just want to take a second to thank Dr. Allison Sullivan and Dr. Bill Wong, who was part of my committee. Couldn't have done it without you guys, and it was great to have Dr. Bill Wong's input as someone with lived experience. And then as well as the AIC faculty, my parents, Steve and Linda, my brother, Steven, my husband, RJ, and my family and friends. References? Any questions?
Sure. For the trainings, who do you think would be best to provide them? Do you think it would be OTs?
I think it'd be helpful to have OTs. I don't think they should be the only ones doing it, but I think it would be helpful to have a bunch of different disciplines in there helping to create and then implement them as well. And whether it be something that's like already pre-recorded and you go online and you do the training, or if it's in person, or maybe someone in the department does it. So it depends, I guess, where it is.
Can you give some suggestions, like what would typical suggestions be to help them better modulate their experience?
For who, like the emergency department or the autistic?
Yeah, for the
individuals?
emergency department, like what would be some suggestions that would be helpful for the autistic people?
So I feel like just increasing that knowledge and providing that training is so important, so that like sometimes when they're going there, not everyone understands. Like it's an invisible disability, so you may not even realize that someone has autism. So being able to understand like what it looks like to help in that situation, and for them to be able to have those supports of like a sensory toolkit or a specific area for them to go to, or even just seeing how, as a whole, we can modify the emergency department to be something that is better for all of us. Because I know when I go, it's a stressful experience, so I can't imagine how it is for these autistic individuals. So being able to just, provide that training, and then even, like I was saying, a thought is like a hospital passport. So having something filled out previously to going to the emergency department, or something that's maybe on their file that will help give better information, so that when they come in, they're reviewing their chart and they're looking at that as well.
Can you explain what a hospital passport is?
Yeah, so it's just like a form that you can fill out beforehand, and it just gives like some of your preferences. If you use a communication device, if you are verbal, nonverbal, like any of your preferences, preferred names, stuff like that, so that you can bring that in with you and they have a better understanding, especially if like it's someone who's going without someone else and it's just them. So like Bill gave a great example during our hearing that say when he's older, if he's in a nursing home and he goes to the hospital, what are they going to be able to do for him? So having that information previously filled out by maybe a family member or someone who may not be able to be reached in that situation, to have that information on them rather than trying to figure it out in the moment where you might not be able to. Any other questions?
Nicole, so when we were talking with Bill the other evening, was it surprising to you as we started talking about the need to find more information about the like firsthand experiences of people, of autistic people in an emergency department? So, how do you think that we can go about doing that effectively?
I think being able to just even go and maybe making a connection with an emergency department and doing a survey, or just getting in there and seeing the experiences of both the health professional as well as the autistic individual, and seeing how they connect, or maybe they don't connect at all. So just being able to get those experiences, and it's so simple to think that it would make sense to get their experiences firsthand, because they're the ones that are experiencing it. But I feel like that's not necessarily always the case.
One thing that I was thinking of after we talked to you is perhaps a hospital or emergency department having an OT, even if they're not a full-time employee of the hospital, as an on-call consultant.
Yep.
And so when someone's being admitted, an autistic person is being admitted, they can, can you come down now? So I think maybe a consultant role would work as well.
Yeah, and I think that's something that was new to me too. Like, I was in the school system and I consult for some of my clients, and being able to understand it's not just direct treatment, but also consulting to help them in their everyday life. So I think us understanding that OTs don't just have to do that direct service, but also they can consult and they can help with different things beforehand rather than just in the moment.
Yeah, and maybe space, like, I know space is a premium in the hospital, but a low-stim area.
Yeah.
Sometimes I've actually recommended people who are with somebody that's having a hard time. The chapel is typically the quietest place in the hospital.
And I feel like it's great for these emergency departments too, because if you have that environment that's inclusive, more people are going to want to come to you, and then you can be better known. More people are going to want to come. So I think that's important for them too on that side.
So our next presenter is Bianca Tochi. And Bianca is going to be discussing her proposal for a mindfulness-based stress reduction curriculum for us poor, stressed out, related therapy service providers. So, Bianca, thank you.
You can just project.
You want to, it'll pick it up for the people on the live stream.
Hi everyone. As she mentioned, my name is Bianca, and today I will be discussing my capstone project with you titled Mindfulness-Based Stress Reduction, a Curriculum for Related Therapy Service Providers. Before we get started here, we've all been sitting and listening to some wonderful presentations. I think this would be a great opportunity to take a moment and just recenter ourselves. And so I invite you all to join me in taking 3 deep breaths where we will inhale through our nose and exhale through our mouths. So we will begin. Inhale. And exhale. We'll inhale again, in through the nose. Feeling the air through your nostrils and your rib cage expanding. And exhale. We'll inhale once more. And exhale. Let the stale old breath dispel. Thank you. And so I ask you to join me in one more practice where we'll bring mindful awareness to an activity like washing hands. So we'll just simulate the practice here. And as we do so, I'd like you to just bring awareness to what you're doing. Think about maybe the textures that you might be feeling in your hands, maybe a scent or smell you might be perceiving at this time, or thoughts that might be coming and going. So we'll just do this for about 10 seconds here. I'm counting, so a couple more seconds. Thank you. So that, my friends, is a great example of a formal and an informal mindfulness practice. As you noticed, we did the breathing technique where it was a little more organized and structured, formal practice. And then we just brought some awareness to an everyday activity like washing hands, informal. So some of you might be asking, what is mindfulness? Before I go into a deep description, I'd like to just briefly summarize it as the cultivation of awareness, being present. So when I graduated college around 2016, I needed something, some form of tools to help me navigate this vast world life. And so I was introduced to mindfulness. And throughout my experiences, I've come across some challenges, obstacles, setbacks, loss. And I found that mindfulness has been such a valuable tool in helping me remain grounded when everything around me feels like it's being uprooted. So I've outlined some of the benefits for you here as stress reduction, pain relief, increased self-awareness, emotional regulation, and improved focus. And so at some point or another, I can attest to experiencing all these benefits. But particularly, I want to talk about the pain relief. There was a time where I went through a physical injury that left me with constant, daily, ongoing, high-intensity pain. And it was a distraction. It was frustrating. So I had to find something. And I integrated mindfulness within my day-to-day activity. And I found that I was able to kind of shift my focus from solely pain, and I was able to experience some form of relief with that shift in mindfulness. So mindfulness, 10 out of 10, would highly recommend. So now to go into the process. So this topic area was selected based on the need to relieve stress and burnout amongst healthcare clinicians. So initially, the targeted audience for this project is related therapy service providers, occupational therapists, physical therapists, speech-language pathologists. It didn't always start that way. When I first started, I was looking into addressing clients that we treat, and then I looked at mental health clinicians. But the factors of accessibility and receptivity of these two groups was something I had to consider. So ultimately, it turned out that related therapy service was a great group. And so the format for this project is program development. It aligns with implementation of a mindfulness program. I spent time gathering data by evaluating sources and having conversations with individuals of this demographic. And so responses from this targeted population, we were able to survey their needs and highlight their concerns. So their responses, along with evidence-based research, contributed to the development of this program. The time frame was about 3 to 4 working months. It was a building block process. So mindfulness. It's been defined as moment-to-moment, non-reactive, non-judgmental awareness, being fully present. Practicing mindfulness involves several methods like those breathing techniques, guided imagery, meditation, mindful movement, and it includes both those formal and informal practices I kind of mentioned in the beginning. So it's not just restricted to formal practices. You can include mindfulness within your everyday activities. And the studies that I came across noted that informal practice was more accessible to individuals than the formal practice. So there's a term I'd like to discuss with you, occupational engagement. It does come up frequently in this discussion. So it's described as the multidimensional interaction between the mind, body, and soul. And some might call it flow. Occupational engagement is the involvement in an occupation with current personal value attached to it. Research says well-being occurs when individuals engage in occupations and experience positive perceived value and positive perceived consequences, both for that individual and the society that they are part of. This quote I have here, I think, really summarizes it best. Occupational engagement is the participation in an activity or occupation with current, significant, positive meaning. And so now to the issue at hand, burnout. Healthcare providers are experiencing burnout along with prior workplace stress, and this is intensifying, with the pandemic, this is intensifying the rates of stress. So burnout and job-related stress amongst healthcare professionals poses as a risk both to areas of health and occupational engagement. Stress influences decision-making within service delivery as well as quality of care. So the negative effects of job stress on healthcare providers are susceptible to extending to the clients that they treat as well. But then we have mindfulness. Mindfulness training has been proven to effectively reduce stress and enhance emotional resilience, particularly for individuals of human service professions. So you might be asking how occupational therapists play a role. Well, different professionals facilitate mindfulness, but research says OTs are well positioned as valuable providers for mindfulness with interventions that can be integrated within daily driven activities of daily living. So for example, cooking, having a meal, folding laundry, washing hands. There's a link between aspects of mindfulness that relates to awareness and presence during occupational engagement, suggesting the power of occupation or valued activity as a starting point for mindfulness practice. Therefore, OTs are in fact equipped to implement mindfulness practice as it complements existing practice. So some of the literature, I just selected a few that really highlighted the benefits of mindfulness here. So while there's a need for further investigation on specifically related therapy service providers, research I came across, Singh et al., the influence of mindfulness training on well-being in human service workers resulted in lower perceived stress, negative affect, depressive symptoms, anxiety, and burnout, while increasing levels of mindfulness, positive affect, life satisfaction, self-compassion for others, and employees within the disability sector. Gil Martin emphasized the potential benefits of a conceptual stress management technique for nurses that implemented intentional mindfulness when engaging in everyday activities, like washing hands. So it supported that mindfulness can be achieved through occupational engagement. Kemper discusses how specific mindfulness training programs can be beneficial and how online trainings can be comparable to more expensive in-person trainings, supporting the benefits of an online model. And finally, a 4-week mindfulness training implemented among 30 healthcare workers in a long-term care geriatric hospital was compared to a control group and reported significantly greater improvement in life satisfaction, general well-being from a baseline to post-mindfulness training. So this demonstrated the benefits of a brief training, in fact. So overall, most studies concluded that participation in mindfulness can yield physical and mental health benefits to clinicians. Now I want to talk about the theory that shaped my program. So the frameworks that this curriculum is rooted in. Social learning theory by Bandura relates to a learning process in social behavior. It proposes that new behaviors can be acquired by observing and modeling others. So this theory is recognized as a great framework for teaching and learning, especially within a web-based learning environment, because it enables learners to interact and observe the results of the interactions while engaging with others, ultimately leading to the possibility of a more cohesive learning group. And then, you've heard this come up a couple times today, the trauma-informed care model. It's an approach in the human service field that assumes individuals are more likely than not to have a history of trauma. And so this model is responsive to their respective needs by integrating this knowledge within a group or an organization's practices or protocols. So this curriculum responds to the needs of related therapy service providers by considering elements of implementation and delivery that might cause stress. So a study by Kemper mentioned that convenience was rated as the most important factor influencing the choice of a mindfulness training. As work demands and stress increase, healthcare professionals may be unwilling to commit to something time-consuming. So these are factors that was considered as I developed this curriculum. So now, to get to the actual curriculum. So just to touch on the goals here, as outlined, to reduce the effects of burnout and stress amongst related therapy service providers within school-based contexts, to improve emotional resilience with use of formal and informal mindfulness practices, and to demonstrate the implications of mindfulness and how occupational engagement can influence health and well-being amongst healthcare providers. The outcomes. So I've outlined the outcomes, and underneath you'll notice a question. It's just an example of the many questions that might assess these outcomes. So for example, participants will demonstrate improved health and well-being through positive responses to stress and burnout. An example of the many questions here is, in the future, how likely are you to use any of the techniques you have learned to address burnout or stress? Another outcome, participants will show improved occupational engagements through mindful participation in activities of daily living, social participation, leisure, work, play. An example of a question that would assess this outcome is, how would you rate the quality of your mindful participation during activities of daily living? And then increased awareness of occupational therapy's role with mindfulness will result from implementation of this program. So how likely are you to recommend this program to colleagues and friends? So the evaluation portion. Here I have the assessment tools. The 5-facet mindfulness questionnaire is a 15-question self-report scale that measures mindfulness with regards to thoughts, experiences, and daily life. It would assess 5 subscales of mindfulness, including observing, describing, acting with awareness, non-judgment, and non-reactivity. And then I have a pre-test, post-test psychometric scale with multiple categories from which respondents would choose and indicate their opinions or feelings about a particular issue, in this case, the curriculum. And so it would be used to measure their experience by examining areas of well-being and occupational engagement. So the first tool is recognized as evidence-based and valuable in measuring mindfulness. The second tool, while it isn't considered evidence-based, the goal is to pilot the program so this tool is valuable in order to gain feedback, gather further information, and implement the concrete program with some evidence-based tools, along with the 5-facet mindfulness questionnaire. And so now the actual curriculum. Although typical mindfulness trainings are in-person group meetings that occur for about 8 weeks, studies I came across demonstrated that even a brief mindfulness training would result in significant benefits amongst healthcare professionals. So an online intervention format is noted to be cost-effective and more accessible, particularly to this group of individuals. So with that being said, this training falls within the category of an abbreviated online model encompassing the framework and components of mindfulness in a condensed method. So this course lasts for up to 6 weeks with a total of 5 sessions. It's asynchronous, weekly online model designed to be viewed independently at your own time, no stress. So the audience, as I've mentioned, is related therapy service providers, OTs, PTs, and speech-language pathologists. So during each session, participants will learn and engage in different forms of mindfulness through formal and informal practices, as I mentioned before. And here are some examples of some formal and informal practices: body scanning, meditation, deep breathing, mindful movement. And then the informal, adding mindful awareness to everyday activities: mindful cleaning, cooking, washing dishes, walking. And so a take-home practice will be provided where guided audios and video mindfulness exercises will be offered with a home practice manual. Participants will also complete weekly discussion posts and self-rated reports to assess their experiences. Participants will be instructed to practice one formal meditation using the audio and video provided, and one informal practice. So for example, during week 2, participants are guided through the practice of deep breathing and asked to practice this throughout the week, as well as bringing mindful awareness to an informal activity throughout the week, such as washing dishes. So I have an example of the actual table summary of my program manual. So here you see in week 2, the topic is deep breathing, and I've outlined a take-home practice for participants to follow. There's a discussion question: what is your relationship with the breath? And then finally, the informal activity or mindfulness practice outlined as mindful washing dishes, the occupational engagement. And then week 4 as follows, similarly. Body scanning is the topic. The take-home practice is outlined. We have a discussion question, and then an occupational engagement or an informal mindfulness practice, which is focused on mindful cooking and meal prep. These are my references, the works cited that helped shape this program. And I'd like to give a big thanks, a special thank you to a handful of people here. First and foremost, I'd like to thank God for making all of this possible. I want to thank my Capstone mentor and Capstone committee member, Dr. Helfrich. During the darkest time of my life, I was met with nothing but compassion, kindness, and patience, and you supported me through the end of this project. So thank you. I thank Dr. Rodriguez, such a lovely and kind spirit on my team. She was so thorough in her support and offering feedback as we got to the end of this project. So I thank you, Dr. Rodriguez. I thank Dr. Sullivan, who has been a constant and wonderful supportive mentor to me throughout my duration at AIC, someone I can always count on. So I really appreciate having you as a mentor. Thank you. I'd like to thank my cousins, my family and friends, and my sorority sisters, everybody who's joining me here on the Zoom. I want to thank you all. And finally, I'd like to thank my wonderful mother, Stella, who could not be here physically, but spiritually, she's all around me. And without her loving support, her guidance, her prayers, I couldn't be here. So I thank you, and I thank you all. Questions? Dr. Barlow.
I would just like to say that you are an amazing speaker. You have done such a great job. This presentation was so well prepared. You are such an engaging speaker. I really hope that in the future you will consider a role that has you in this light, whether it be advocacy through AOT PAC or president of AOTA. I hope for you. A professor or some role where you are really using this skill that you have, because it is fantastic. And thank you for the work that you've done.
Thank you very much. Jenna.
Could you give an example of mindful cooking or something like that?
Sure. So that, just to break it down, it might look like, again, bringing mindful awareness to your activity. And so you might just take a moment to notice what's involved in your cooking process, what you're feeling like, what cooking inspires you to feel, emotions or thoughts that might be coming, sensations. You know, as OT, we're really familiar with sensory. So smells, sights, the colors. If you're putting together a nice pasta with some bell peppers, you might just be mindful of the activity throughout that process. So thank you. Dr. Sullivan.
Bianca, where are you planning to implement your curriculum? What's next steps for this project?
Good question. Something I've been wondering and thinking about too. Well, I think the next few steps would include partnering and just trying to connect with individuals who have this same mindset and have already taken some steps in this area. For example, I've talked to Dr. Helfrich about somebody she knows personally, and just maybe even just discussing if they have certain assessment tools that they would use for a program like this. So, along with related therapy service providers, I think it would be appropriate to implement something like this in whatever work setting I'm in. I think that would be a great place to start. Yes, Dr. Taylor.
Might I suggest an AOTA short course?
Oh.
So deadline is coming up, but June 2nd, I think that as professionals, we're all experiencing this burnout. We're living it, we're breathing it, and I think a lot of people could benefit from it. And I think that you could be an amazing, engaging speaker, just like Dr. Barlow said, in offering this type of a resource to the OT profession.
I wasn't aware. And June 2nd is my mom's birthday.
It was written in the stars.
Thank you.
So I was curious if you were in touch with other OTs who were doing this, or we used to do something similar at a psychiatric hospital, and I was just wondering, is there a setting where this is already going on?
I believe this type of program, from what I came across, this type of program has been shaped in different ways. Mindfulness looks differently, but you have certain components you have to maintain. But honestly, because my research wasn't really focused on that, I'm not quite sure if it's being implemented fully in a particular setting currently. But I do know that plenty of people, or some people I'm aware of, are really looking into this type of program for burnout. So my next step is to connect with them so I can know how we can move forward. Yes?
Nicole's going to kill me for talking, but I'm going to talk anyhow. So I just want to give you perspective on what you're talking about. This is real life stuff. I work for CVS, and we have a mindfulness program. Literally yesterday, we had a whole 2-hour speech about burnout. And 2 hours talking about it. And one of the funny things they said is for burnout, I see everyone has these things, right? And they literally tell you, take your phone at night, put it in the other room, put it in get a little blanket for it, a little blanket, and you put it to sleep in the other room. And I work in IT, I can never do that, but that's literally what the people are talking about. So it's real life stuff. It's not occupational therapy, but in CVS, we have mindfulness rooms. You go to a room and just chill out a little bit. So it's real life stuff. It's being implemented at Fortune 5.
That's good perspective. It just drives me to push forward. Thank you. Yes?
What about the school district that you worked with in doing release?
Yeah, I'm still in contact with them. And in this busy season, and then with burnout, it was difficult to connect with as many individuals as I could. But they were open to just learning more about it to see if it's something I could bring to their district. Yes?
So wonderful job. Not more to add to your plate, but I also think this would be an amazing module to also incorporate into colleges for students, even OT students or any students, especially if it's self on their own time. But just seeing how everyone is getting burnt out, something to add to your plate to possibly look into adding it to academia.
I think that's a great suggestion, just because in this time period of the pandemic, I think with burnout, we don't want to scare people away from the profession. So I think that would be something to definitely consider, and also to equip students to step out and implement it themselves. Thank you.
So we are doing a great job of bringing these capstones across in a efficient manner. I wasn't sure, Caitlin, did you want to just stick with your schedule? Because I didn't know if there'd be people tuning in. 5 minutes? Oh, you're here? And Dr. Nafai? Is Dr. Nafai?
Might be joining virtually. I haven't spoken to him since this morning.
why don't we give it, right? And also just thinking about Bianca's wonderful advice with mindfulness. I know this is a long day for a lot of us. Why don't we take 5 minutes, get up, right? Walk around a little bit and come back so that people can focus and concentrate, give our end of the day speakers our full attention.
So this is it. This is the slideshow. We just
You're welcome. bring things back and have our last two presentations for the day. Our next presentation involves the creation of a virtual resource to support OT best practice for family and caregiver training. This was a Capstone project created by Caitlin Sousa. So Caitlin, take it away.
All right, so as Dr. Sullivan mentioned, my presentation discusses the journey that I took through this post-professional OTB process and how I've used the knowledge gained along the way to create a website that guides practitioners when providing education to a patient's family members. So before I dive into the details of my final Capstone project, I'd like to reflect on the process that I took to get here. It was truly the coursework that had guided me to this point. I began this doctoral journey after the COVID-19 pandemic hit Massachusetts and put my life as I knew it on pause. I began this journey in the fall of 2020 and continued my work as a level 2 fieldwork student at a long-term acute care facility. At this time, the pandemic was still leaving a high level of uncertainty for healthcare workers, patients, education, and my own professional journey. I worked with a variety of patients who would be leaving our facility to go back home, requiring some level of need from a family caregiver. However, during this level 2 fieldwork experience, I was faced with the dilemma of educating family members while navigating the state and federal COVID protocols. Visitation hours were discontinued at the time, and this meant that most of our communication was through phone calls. This was one of the many challenges that the pandemic presented, but it was one that I felt was not only impacting the outcomes for my patients, but it was also affecting my educational experience. This left me with a desire to make a change and a passion for expressing the importance of educating caregivers. My experience working through this level 2 fieldwork and the start of this post-professional program led me to reflect on my own family's experience as well. My grandfather has Parkinson's disease, and through his journey, he has relied heavily on the caregiving of my family members. But none of us have ever participated in a formal caregiver education program or have been given a clear path to a resource of that kind. We've been given recommendations for home modifications or exercise programs, but never has the emphasis truly been on ensuring that his caregivers have the proper knowledge and feel prepared to care for him. Again, I viewed this as a missed opportunity for occupational therapy practitioners and an area for need for research and program development. So when I began this academic journey, I had this passion in mind, but I didn't quite have an idea of how to impact this area of practice or what type of a project I would develop. I was encouraged along the way that by starting with this passion, I was off to a great start. Through the different courses I took in this process, I was able to develop this passion into a specific project. I was able to take a deep dive into the theoretical frameworks that guide occupational therapy education programs and adult continuing education efforts. Additionally, I was able to investigate the different programs within the community that provide caregiver education training, and discovered a need for the specific expertise of an occupational therapist. I then began to investigate current research and literature about the effectiveness of involving a family caregiver early on in the treatment process of a patient. This literature review supported the creation of my website design and served as the foundation for the written manual that I produced. This literature review supports that when practitioners are working with patients whose discharge plans are to go home with family caregivers, it is imperative for us to address the needs of those caregivers. Caregivers are often overwhelmed by the amount of assistance that their loved one might need when transitioning back home after a hospital stay or long-term rehabilitation. Their caregiver responsibilities have likely increased, and their roles have changed. approximately 39.8 million caregivers provide care to adults with a disability or an illness. Family caregivers spend on average 24.4 hours per week providing care. Nearly 1 in 4 caregivers spends 41 hours or more per week providing care. Research completed by Young and colleagues demonstrates that the level of preparedness the family caregiver has directly impacts the long-term outcomes of patients. The researchers' findings suggest a comprehensive, systematic caregiver assessment conducted during rehabilitation can help the healthcare team to develop a plan to address the unmet needs and better prepare family caregivers to take on their caregiving role. A systematic review by Van Dyke and colleagues demonstrated that in-hospital caregiver involvement can increase the functional performance in older adults. Additionally, the authors determined that caregiver involvement can influence the quality of life of the patient and the caregiver, readmission rates, discharge location, and even mortality. The stronger a caregiver's ability to provide quality informal care, the better the long-term rehabilitation of the patient will be. Research by Esom, Olson, and Coleman demonstrated that participation in caregiver education programs cause a direct impact on caregiver confidence and self-efficacy, as well as on caregiver frustration levels. Through the duration of their program, the caregivers were provided with new techniques to problem solve and communicate. Additionally, literature shows that state and federal guidelines with social distancing have had an impact on the number of and duration of family visits of patients in acute care therapy settings. Due to this, rehabilitation staff is required to utilize phone calls and discuss patient current level of function and recommendations for discharge when necessary. However, this lack of hands-on caregiver education and training can endanger our patients and place them at risk for re-injury or new onset of illness. During hospitalization, it is important for caregivers to be involved in treatment to ensure the best care will be given to these patients post-discharge. OT practitioners need to have a supportive role in this discharge planning. OT practitioners are unique from other healthcare professionals as we are skilled in providing a comprehensive approach to our patients and their families. The website I have created includes content related to the benefits for caregivers, strategies to prepare the practitioner, and content to help build sessions in real time. Current research supports the need for OT practitioners to provide caregiver education, but there is need for increased preparedness of our practitioners to supply these sessions. Furthermore, practitioners and students can be overwhelmed by the many roles and responsibilities that an OT practitioner needs to have. According to Park, occupational therapists experience high levels of work-related job stress as they require specialized knowledge and individualized approaches for treatment interventions, communication, and teamwork among specialized treatment areas. This work-related stress can be higher with new practitioners or level 2 fieldwork students because they're still learning while on the job. OT students are given skills and knowledge about what patients and their families might need for discharge, but they do not necessarily receive training on providing health literacy or education sessions until they're in the field. Current students and new practitioners often rely on virtual resources for guidance within their practice, and new practitioners often rely on virtual resources for guidance, education methods, and websites created by other occupational therapists. And this is why I was motivated to create a virtual resource. I think I messed up my slides there, so I talked a lot on this slide, but some of it was from the previous slide, so just want to show that. So my capstone has been structured around these needs and founded in research. I have been guided to create these 2 learning opportunities. The first being the creation of a website to guide practitioners, and the second being a learning opportunity for future practitioners. The creation of this new website will provide a clear path for practitioners who want to provide quality family caregiver education sessions and the educational collaboration with master's level OT students will ensure that the new generation of therapists understand the importance of connecting with their family members, with the family members of their patients. So after identifying the need for this tool, a website domain was created using the program called WebNode. This is a screenshot image of the homepage of the website, and if I click on it, it should take us, oh, I forgot, we already opened it. So this is the homepage of the website. As you can see here, these are the different tabs and different content on the website. We have an About page. The About page highlights the supporting literature that guided the creation of the website, and the Resources to Learn More page includes continuing education opportunities for occupational therapy practitioners, and also the reference list. The bulk of the content is outlined on the Tips for Caregiver Education and Training page. OT practitioners are given resources to guide their preparation for caregiver education sessions, key topics that can be included in these sessions, and resources that can be provided to any caregiver. I can try and zoom in a little to make this a little bit bigger. So on this preparation subpage, OT practitioners can learn about when to connect with caregivers and how to navigate difficult conversations. OT practitioners are provided with a list of possible assessment tools that will guide them to determine a patient's need for assistance with daily care tasks. Once OT practitioners have determined the need areas of the patient, it's important for them to interview their caregivers to assess their level of competence and preparedness for discharge. Together, the OT practitioner and the family member can determine the areas where education and training may be useful. OT practitioners should remember to be direct and to provide details to the level of assistance needed, ensure the caregiver has a true understanding of what will be required of them. Going back to the previous page. These content areas here include key topics that should be included in any caregiver education effort. Tips on providing caregivers with stress management and communication strategies are included, and that would be on these two tabs here. Here is the communication and behavior strategies page. There's outlines for discussing communication with their loved one, communicating with their family and friends, and also communicating with healthcare professionals. For the sake of time, I'm going a little bit quick through this, but when we get to the questions section of this, we can dive deeper if anyone needs to see something. This is the stress management and coping strategies page. It discusses steps to manage stress, tips on how to ask for help, and some helpful takeaways for the caregiver regarding that sort of stress management strategies. And then going back again to the content areas. This specific diagnoses tab I'll discuss deeper in just a moment, but this will give practitioners outlines and handouts to give to caregivers in their real-time education sessions related to a specific diagnosis or an injury. The last and most important piece when conducting an education session is providing caregivers with resources that they can use in the future. The Resources for Caregivers subpage, which is here, offers direct links to websites such as the Family Caregiver Alliance, National Institute of Aging, or the Elder Care Locator. Practitioners are also encouraged to find local support groups and community resources that they can provide to the caregiver. So diving deeper into the specific diagnoses subpage and the second component of my capstone project, I've developed a lesson plan and related assignment for the Masters of OT students here at American International College. as part of their occupational therapy process aging course. This course is structured in the last semester of coursework before students begin their level 2 fieldwork. And at this time, students have the knowledge of occupational therapy domain and process and have learned about the various client populations, client factors, and treatment process in regard to a variety of diagnoses or conditions. Following Fink's self-directed guide to designing courses for significant learning, the following goals have been developed for this learning opportunity. Students will identify the importance of advocating and implementing quality caregiver education sessions for a patient's loved ones. And students will formulate an effective and detailed caregiver education session to support the continued safety and positive outcomes for patients after discharge. During the designed lecture, the students will listen to a narrated presentation that was prepared by myself that focuses on the importance of providing caregiver education and training when working with the aging adult population. Additionally, students will produce an outline and a handout for caregiver education within a specific need area. Some examples of the specific need areas are listed here, as well as a completed example of the assignment. And I can just show that briefly. So this would be an example of an outline that the students would produce. This one is geared towards communication techniques for Alzheimer's and related dementias. So this is the outline that an OT practitioner would follow in a caregiver education session. And then this handout could be given to those caregivers as it's sort of a take-home to highlight some of the things that could be discussed. And it also includes some resources. Specific assignment instructions and a rubric have been developed, which is also linked here, just to briefly show you that it is on the website. And I think I will go back to my PowerPoint. I did include some screenshots here, but I thought that showing the actual website and how all of it is linked together would be a more efficient way to demonstrate the use of this website. So, looping it all together, the evidence that's supporting my work demonstrates the idea that by improving caregiver preparedness, you can also improve patient functional status. The ability to recognize the need for caregiver education programs is an important piece to ensuring the safety of clients post-discharge from a care facility. Additionally, it is important Additionally, it is important that knowledge of supplying caregiver education is included in occupational therapy education. This resource provides an opportunity to assist in a solution to both stated areas of concern by serving as an educational tool for not only current practitioners, but also students. The creation of this website creates the following impact on OT practice. Number one, practitioners will be prepared for education sessions. This will then have a direct link to caregivers' preparedness to take on their roles. And then so on and so forth. Our patients will have increased safety and reach their long-term goals. Moving forward, my goals for the future include the implementation of this learning opportunity for the master's level students and growing the content of the website. In the future, this may include building separate content pages to be geared towards the different populations that could be viewing this website. Right now, most of the content is geared towards practitioners, but adding different subpages geared towards caregivers or geared towards students would be helpful. Additionally, it's my goal to publicly share the website using social media groups or AOTA discussion forums. A program implementation and impact evaluation will explore the effectiveness of the website in accomplishing the following goals. Number one, OT practitioners who view the website will report an increase in competence and confidence when educating caregivers. Second, caregivers who receive an education session from a practitioner who's viewed the website will report an increase in their self-confidence within their caregiving role. And lastly, students who participate in the lecture and complete the related assignment will identify the importance of providing caregiver education sessions. This evaluation may include surveys or interviews with these three populations. This information can be developed into a qualitative research article and published in academic journals. The OT Practitioners Educating Caregivers website is designed to grow over time and provides an endless opportunity for my work to continue to impact OT practice. So at this time, I'd really like to extend my gratitude to both Dr. Nafai and Dr. Taylor for their help in this capstone process, but also to Dr. Sullivan and Dr. Helfrich for all of the help along the way to get here, and also to my family and friends for their patience and support throughout this entire journey. I've also included my references, and I'd like to open the floor for questions, or I could go back to the website to explore more.
I think your information for caregivers is very important. However, there are many caregivers that are not English speakers, native English speakers.
Mhm.
And so have you thought about having some of that important information translated into other languages?
That's a great thought, and I think there's also a lot of online resources for translation in the moment, different apps and stuff like that that could be included on the website as links for practitioners to include. That would be a great addition. Sorry, the computer screen's coming in the way. I don't know.
To build on that comment, I think that this project is phenomenal.
Thank you.
And it just has so many options for other students to take on and do additional capstones from in many different ways, in other languages, in other areas, and we've talked about some of those already, but I think the more I see it, the more I think of more projects.
Yeah, creating a snowball effect.
But I do have one question. After reviewing all this, I didn't see this until you presented it. On the session outline that you showed us, there's a QR code on there.
Oh, yes.
What's that for?
So that is just a direct link to the website. So this, as I mentioned, this outline is for the practitioner to use to guide their education session. So including the QR code was actually an idea of Dr. Taylor's, but it's just a direct link, and you guys could probably use it right now. But it would just bring you right to the homepage of the website. So it would just bring you right here.
You want to try it?
Let's see if I can zoom in here. I don't know if it's big enough for your phones to see it.
We're on your page.
No, sorry. We can zoom in on
Oh, yes. Yeah, Lois?
Great job.
Since play is the antidote to loneliness, I was just curious if there was something on here, if I missed it, where there is a page for activities in the moment.
Yeah, I
Get more in the moment opportunities.
Yeah, I think that that is a great addition too, and I think the way that the website is designed, it's going to continue to grow, and I think that would be a great area. But under the stress management page, there is some information here for the caregiver to, really take some time for themselves and to really include their own activities of daily living and their own passions, their own occupations, and not to let, their caregiving role overshadow that.
I think I was meaning more of what's a way that the caregiver can be more playful with the person that they're taking care of.
Okay, so like
How can
to
there be more
give,
play between the two of them.
yeah, more interaction between the two of them. Yeah, that's a great area to continue to develop. Yeah.
I was just thinking, it's very thorough, first of all, really extensive. But it seems like another component that if you are opening up to caregivers as well, if you provide like a discussion section, that they can either say like, hey, this really worked, or this approach within what you suggested worked.
Sure.
Might be really helpful as
Yeah,
well.
maybe like a blog or.
Yeah, blog
yeah.
spot, yeah.
Absolutely. Yeah.
I just wanted to commend you being a part of this and the immense amount of work that you did, because this is absolutely incredible. How do I say this? The value add that this is going to have to Dr. Defy's class, not only providing the education that like she's already giving to the master's level students, but also to the profession, because we can come up with diagnosis after diagnosis after diagnosis and all of these considerations that can be added. I think that this is just an invaluable resource. So I just want to applaud you that you took an undertaking that was like this, which I can commiserate with in my own capstone, and you were able to make this very palatable in a presentation. So
yeah, and I want to compliment too. I think that the team that between the three of us really does open this up for the future development and the future use of the students, because one, he can use it in the classroom, but then it can also be, advocated for fieldwork use. The students can look back and reflect on this during fieldwork.
I just want to comment, I'm really going to get this shirt made. You officially are the upper echelon of like a triple yellow jacket now, right?
Yes. Yeah, I essentially made my own entry-level OTD program.
Yeah. So you have your 3 degrees from here. Congratulations on that. But the idea of giving back to the place that educated you, I was sitting here going, I think that's so great. But to comment on Dr. Helfer said, that was where I was thinking, like, in my world, I'm thinking of home design ergonomics for the elders, and I'm thinking, oh my gosh, there could be another link there, is where I was thinking. So, you sort of agree with what she was saying. I think this has such potential.
Yeah, and I think that was the point. Like, it's not finished, and it really was the foundation that was my goal, to get this started and to figure out how to use it. So, yeah, I'm excited to see it grow.
Fantastic.
I'm going to close out of some of these tabs.
Very gratifying.
Very thorough.
That was something that developed over time, because it didn't start that way.
Okay, last but not least, our final presenter today, Lois Gold, will be talking about including affect and action in holistic practice of occupational therapy. Lois, click that.
It's a lengthy title. Here. Okay. I think so. And just to get through the slides. This one. Okay. All right. So I'm Lois Gold. I'm from Miami. I'm the one from the South. Just so you know, I had never heard of American International College prior to coming here. However, I'm tremendously grateful. I read an article in a research magazine, and this is how I ended up here and found the faculty that I was searching for. So although it might seem like a random choice that I'm from Miami, however, it was not random. So I do want to add that. Gratitude, wow, I'm old. So it took a long time to get here. So my mentors started from the University of Florida, the Great Gator Nation. And my original mentors were Dr. Leila Lorenz, who was our department chair, I know, wow, who is joining us today, Dr. Kay Walker, and Dr. Sandy Adams. And they have been a guiding light in my career from beginning to now. Continuing gratitude for my mentor and thinking partner, editor, dear friend is Molly Romer-Witten. She's a psychoanalyst in Chicago. Stanley Greenspan and Serena Weeder and my DIR colleagues provided me a mid-course correction in my career to pursue a path of psychoanalytic infant mental health and learning and utilizing and teaching the DIR floor time model. Madonna Nash, who is an NDT instructor, gives me the space to create ideas for teaching others, and we've been teaching quite a bit. Gratitude for my dear friends who encouraged me to get back to my homework and paper writing. Gratitude for my husband, Michael, who's here for his unwavering support. Talia, my daughter, who helps me make all my papers pretty. She was my tech support and reminds me to stop pushing buttons, so I always say that, while providing tech support. And my son, Daniel, who's always so proud of his mom, who missed his flight today. And lastly, gratitude to Dr. Allison Sullivan and the members of my committee, Dr. Christine Helfrich and Dr. Joanne Flanagan, for their continued patience and mentorship, and in memory of my very proud dad, Stanley Gold, who is a native of Brockton, Massachusetts. So see, we're not so far away from home. So why did I embark on this educational journey at the age of 60? So my purpose, I was first attracted to occupational therapy 40 plus years ago because of my interest in neuroscience. I've helped countless children and families. I've taught nationally. However, now I want to help the children by teaching other OTs what I've learned. So I would like a platform to share my acquired knowledge and passion. I wrote this paper with hopes of being published in the American Journal of Occupational Therapy in the Issue Is section, which is an opinion piece. The benefits of a post-professional OTD education. I've become far more organized in my thinking. It is true. I can speak to what's missing from a program, a treatment plan, a lesson plan, etc. Since we all improve our ability to think through established relationships, I benefited from conversing with my cohort as well as my professors. I was able to articulate why my specialty of using a psychoanalytic infant mental health paradigm was consistent with principles of occupational therapy. I've always been an occupational therapist. I'm still an occupational therapist, and I still want to be one. And last but not least was becoming scholarly, although that word still intimidates me just a tad. So holistic and its meaning in occupational therapy. So forever, it's always been about the mind and the body, are always considered within the context of each other. However, now it's been a bit more expanded through the years, and now the whole person is thought about within the context of relationship, the environment, and culture throughout the lifespan. So affect and action. It's easier to understand the concept of affect and action if we actually see it and experience it. So let's take a moment and we're going to try and imitate Allison Felix up at the top. She's holding her gold medal. So I invite you to hold a medal in your hand, and I want you to try as best as you can to imitate exactly what her facial expression seems like. I want you to imitate, think about her smile, where her eyes are, how she's holding it in her hand. And now I want you to think about the expression on your face. I want you to feel about the shift in your posture. I want you to feel your muscles activating in your body, and I want you to think about your focus. And this, my friends, are affect and action working together to experience it. Now, for the next picture, this is a different affect. And so now we're going to look at This is her running. And this is my favorite sport, is sitting in front of watching track and field of every Olympics and stopping the TV and going, wow, let's just look at that, okay? So if we can all look at, my mind is blank on her name. Anyhow, she's very impressive. She went really fast. If we can now put your arms in the position of hers, she's doing the 4x100, for those of you who don't remember. And now look at her facial expression. Get your lips in that position. She has her mouth closed, and that gives us organization to the system, to the nervous system. Her focus, and again, feel the expression on your face, feel the shift in your posture, feel your muscles activating in your body, and now think about your focus. So the first thing I always notice when I'm doing this with anyone who I'm teaching, this is always a part of my teaching, only we usually have about 6 more types of facial expressions, is the first thing I do is I sit up tall. And so I always find that interesting, again, how all of this is connected. So if we see a bunch of people who look slouchy in their chair and they look bored, it's because they actually are. And so then that's in their body, okay? And so those who are riveted and really attending, look, our bodies are activated as well. So affect is our feelings. It lives inside our body. The feeling of anger, excitement, etc. Action is how we move and what we do. Affect is the basis of relationships, it's the basis of participation, and it is the basis of meaning making. What are the affects? So Mark Solms, I'll just direct you to the bottom. He's a neuropsychoanalyst, and he's a really smart guy, and he knows a lot about the science of affect. And so he wrote this in 2018. It hadn't really been spoken about since a long time ago when we learned the basic affects, which we'll get to. But the human infant is not a blank slate. Like all other species, we're born with a set of innate needs, and these needs are ultimately felt as affects. So there's emotional needs, which are felt as separation, distress, rage, fear, etc. There's bodily needs, which are felt as hunger, thirst, sleepiness. I feel hungry, I feel thirsty. Sensory ones, which are felt as pain, disgust, and surprise. So the original work was done a long time ago in the early 60s, and essentially everything was organized into positive affects, neutral affects, which is surprise, and negative affects. And surprise is something that I use a lot in my work, so that when something happens, you know that oopsie that children take, and you don't know if you should make a big deal out of it, but then you should notice that they got hurt? So we just say, oh, that was a surprise. See, that's a neutral way of commenting on of an event that occurred, but without adding your own affective twist to it. You're just saying, that was a surprise. So let's learn more about affect. Affect brings specificity to our knowledge about emotions and relationships. Affect, which transforms to emotions, it transforms to emotions, and action occur simultaneously, and therefore both must be considered by OT. You can also hear that affect and action are two sides of the same coin. For a child to participate in meaningful occupations, they must be able to regulate their affect, which is also known as feelings, and relate to others. As we understand the difficulties in our pediatric clients, we consider the development of relationships and affect within the child's system. And this is the focus of my work. I focus on relationships and I focus on affect. The problems that I discovered. Affect, which is a neurophysiological process, when used as a search term in the American Journal of Occupational Therapy, as well as an OT practice magazine, Affect was used as a verb rather than a noun. Occupational therapy literature describes the importance of relationships. It's written everywhere. Yet there's no detailed explanation and sequence of exactly how relationships evolve. In OT literature, we rely on labels such as attention difficulties, regulation, attachment, handwriting. However, these labels lack the depth necessary to make effective changes with our clients. It keeps us limited in our scope and using manualized recipes. Sensory sensitivities are exacerbated by anxiety. How do we know the difference? Confusing symptoms for problems invites linear thinking. Sensory diets are often focused on sensation within the context of the activity. I just saw this the other day. Again, sensory diet is all the ideas are listed on a piece of paper. And they're all activities for the child to do. Never once including relationship. Never once speaking about what is the adaptive response that we're looking for within the context of relationship. So the sensory diets are focused on sensation within the context of activity rather than activities that would provide sensation within the context of relationships. So important contributions to occupational therapy that were relevant to my topic. In 1965, and I do remember reading about her when I was in OT school, it wasn't very exciting. However, now it's very exciting. In 1965, Gail Fiedler, who was an occupational therapist, she was married to a psychoanalyst, and she included psychoanalysis and specifically object relations into occupational therapy. It was part of her Eleanor Clark Slagle lecture. Object relations informs us about the development of relationships. Melanie Klein and later the person who learned from her, Donald Winnicott, who was a pediatrician, were instrumental in developing this theory as well as several other object relation people. Melanie Klein taught us about the internal world within the context of our body and relationship with primary caregiver, which is also known as the primary object. Somebody had that in there. Oh, Jenna, you did. About the primary object for intimacy. So object relations theory considers the context of relationship. Winnicott spoke about how we must see the baby in the context of the relationship with their primary caregiver. So there's no such thing as a baby alone. Motor science sees the individual within the context of their environment. There's no such thing as a person who just exists. As occupational therapists, we're trained to see our client within the context of our therapeutic relationship. And we also embrace seeing our client within their cultural context. Leila Lorenz, who hopefully is joining us today, in 1970, Dr. Lorenz introduced a framework of developmental theory into occupational therapy practice. I was fortunate enough that she's the one who taught me her theory. She spoke about the importance of viewing the child in a holistic manner. We use multiple perspectives, including psychoanalysis, when considering the development of the child. And these processes occur simultaneously. And she has added that simultaneous word. It isn't that they operate separately. They operate in a simultaneous fashion. And thankfully she's with us, so she can keep adding to her work. So how do we learn about the development of relationships and affect? Interprofessional education, also known as IPE, is the platform that teaches us the importance of working with our colleagues, so we can learn from them. Everyone is on an equal playing field. There's no hierarchy. Everyone is considered an expert in their field. Psychologists often specialize in cognitive behavioral therapy, also known as CBT, and others are trained as psychoanalysts, or others use a psychodynamic approach. Psychodynamic and psychoanalytic often go interchangeably. There's a few little details that are different, but they're pretty much similar. They're similar enough. CBT uses a linear approach and is simpler to use and much simpler to learn. This often focuses on behaviors and utilizes checklists, while psychoanalysis is a dynamic approach that's far more complex to use and learn, as it focuses on the foundations of affect and relating. Psychoanalysis gives us a much bigger picture. Behavior is a solution to a problem. I've known this sentence for so long, it's hard to remember when I didn't know it. But it is something that I find is so crucial for all of us to understand. That behavior is so attractive to just want to stop it, eradicate it, put weed kill on it. However, we need to understand what is the underlying problem. When using a psychoanalytic approach, the focus is on understanding the problem to eventually eradicate the symptoms. If we only address the symptoms, there will be another symptom to take its place. It is imperative to understand the problems in its complexity rather than teaching a skill in isolation without the context of relationship. If we work at a deeper level of complexity, as we use a psychoanalytic approach, we can hope for generalizability. We want growth for the children rather than line item skill building. What do we see when an activity is meaningful to the child? Affect cues include shared attention, curiosity, and the best of all, desire. So areas for future study: the role of affect in reflective supervision. Hold on, please. Reflective supervision. The role of affect in the therapeutic use of self. For those of you who aren't familiar, reflective supervision is something that we as therapists pursue in order to understand the impact of our own affects on our patients. The therapeutic use of self, the role of affect in that would be how to expand ourself and become more mindful of our affects, the unconscious part as well as the conscious part. Infant mental health. This is 0 to 3 or 0 to 5-year-olds, and again, understanding our own affects when dealing with parents. Again, this is something that we see. Early intervention is supposed to include parents. However, working with parents is what becomes so overwhelming for the field. Okay? Recognizing affect cues in motor and sensory behaviors. So that means I can look at a motor or sensory behavior and know what it is that the child might be experiencing feeling-wise. Increasing our understanding of affect and its neurophysiology. OTs, we learn neurophysiology and neuroanatomy, and this should be right up there and included. This is not foreign to us, it's familiar territory. So where can we learn about the science of affect? So Mark Solms, who I mentioned before, he's a neuropsychoanalyst. He's from South Africa. He discusses the neurophysiology of affect. He is an incredibly prolific writer, and he's also published books. His most recent book is called The Hidden Spring. Vittorio Galise He was the discoverer of mirror neurons, and he speaks about neurophysiology and social neuroscience. Daniel Stern and his work on vitality affects. And Jack Panskep developed what he calls affective neuroscience. And these are my references. And I'm here for questions. Yes. Yes.
I just want to I'm wondering when in your career can you pinpoint when your drive for this topic specifically on affect? I know you're very passionate about it. When did it become?
I think when I first met Stanley Greenspan and Serena Weider from DIR Floor Time, I was the original OT, and that he was starting his organization on. And he is a psychoanalyst and a child psychiatrist. And so he was the one who introduced. I still remember when I first met him and I was introduced to him, I said, well, I kind of do what he kind of does, but we just call it different things. And, you know, and that kind of became the beginning of the brainwashing process. Yeah, we just call it different. So it's a whole field within itself. He also very much from the beginning taught me that OT was just as important as the physician sitting at the table, because the physicians or the psychologists or the speech people or the PT people or the educators didn't know anything about how the sensory and the motor system work, nor do they understand activity analysis. So OT certainly has a seat at the table. So I would say that was really that mid-course correction that I spoke about it with my gratitude. And from there, he was the psychoanalyst. And so he was not necessarily the originator, the original thinker of these topics. He was the one who integrated these concepts. So you can find things that he has said that actually people before him said, and it isn't that he copied them. What he did geniusly was integrate them so that all the professions could use it. He started in infant mental health, but it was in the infant mental health where the parent was the issue. And he said, hey, we have to work with families where kids are having developmental issues. So he just transformed the whole field.
Thank you.
Sure. Any other questions? Yes?
Lois, so I know in developing this topic, you have experienced a considerable amount of frustration in trying to influence a wider audience of OTs who seem very focused on cognitive behavioral therapy, and I know from the mental health textbooks that we use in OT curriculum that there's precious little on this particular topic. So can you describe some of the outcomes, negative outcomes that you've seen from treatment that doesn't put affect, that it doesn't explicitly identify affect as an important treatment priority when OTs are working with infants and young children?
So I would probably say the number one issue of using cognitive line item thinking is generalization, is the ability for these children to be able to generalize these capacities and these new capacity to function in multiple settings. So I would say that that is probably the biggest thing. Second of all, the families very much, look forward to dropping off for their own respite, dropping off to the therapist as if the therapist has magic fairy dust, and rather than including the family as part of the treatment plan. So again, this is something that's very much emphasized in the development of affect and relating, that the child came with their mom, with their primary caregiver, their father, whoever is taking care of them, okay? So I would say generalization, being able to generalize these capacities to other areas. I think when you take one symptom away, you just get another symptom in its place. I also think that in the cognitive behavioral world, there is a very certain way about being good and being bad. So in that way, I have a lollipop jar in my office. Every kid just has to have their shoes on to have a lollipop. Because who am I to say, if they got very angry today in our session, and they were able to share, or they were able to dilute some of their rage, does that mean they had a bad day? Because it's not a pretty emotion? So who are we? It's saying we only want the children to have these positive, wonderful emotions, and the rest of the emotions, we don't want to hear about it. In fact, if we see it, there's something wrong. No. They need to be regulated throughout all the affect states. That's what we're looking at. So there's no such thing as anger management. You would have to also have excitement management, because it's the same kid who's coming in from PE and who can't get settled. What's that called? He's excited. He just got done running around, okay? So we want to know that he can calm down from PE, which was fun, as opposed to calm down from he just lost it because somebody won and he lost, or something along those lines. What's the difference? It's all the same. Yes?
I love your work, Lois. Great job.
Thank you.
Jane Singer, as you know, is a leader in mental health. And so
I didn't hear the name you mentioned.
Jane Singer.
Okay.
And for Touch Points, Brazelton Touch Points, they have that new developmental journey map.
Okay.
And one of the items is about behavior, and it's all about talking with the parents. And I think that your work could really add, because you know, in that in the map, they have so much conversation for therapists, for pediatricians on how to talk to families. So in that, you know, to add on to her work for our students, for your therapists, right? If you could give that language of how to talk to families. So this is a behavior, let's talk about that behavior. What does it look like? And to provide, with your knowledge, to provide examples for clinicians of what those behaviors are and what they might need. Because the map is new, right? It's really new. They're adding on as they go. I think you have so much to offer in that field.
Thank you.
I just
Thank
think
you.
Your work is great.
You know, regarding Dr. Brazelton, for those of you who aren't familiar, he died not too long ago. I was really just a tremendous privilege. I got to see him handle a baby. We had a 90th birthday party for him. So I'm very familiar with his work. And he and Stanley Greenspan were all very good friends. You know, these are just all people who have now, they're all passing at this point. And so this is all about involving the parents and not just leaving them in the waiting room. This is just really about that. And you know, again, in early intervention or to be able to get to EI programming, right? It was all about getting the parents involved, yet the information about teaching and understanding about the development of relating, the development of affect, how that all works together, it's not in the literature. And so therefore it makes the therapist very frustrated about how to manage the families, because I don't have just one patient. I have the child, I have the parents, I have the grandparents if they're involved, I have the nanny. I'm dealing with many people. So it's really being able to manage, and then the parents are coming with their own individual differences, their own affect regulation challenges, their own traumas, etc.
What I'm trying to express to you is, in addition to this HR article that you
Yes.
want to write, how else are you going to get your work out there?
Good
Right?
question.
So maybe-
Good question. So, you know, I've started small by teaching. You know, I've been doing some courses for NDT Association as well as for ICDL, which is one of the Greenspan organizations. And that's how I've been doing it, slowly but surely. Also through the DIR floor time world. However, these topics that I wrote about things that require further discussion are truly things that require further discussion, because they're holes. They're holes in the field, and there's something that it just makes first of all, if affect is the glue that keeps processing together, then affect is the glue that keeps our work together. Okay? So I think there's a lot more writing to be done. I don't think I would do it alone. I think I would have a person with me now, right? Correct? Anyhow, right, Willard and Spackman. So thanks to Dr. Helfrich, I got to write something in the new Willard and Spackman textbook, just on simple turn taking. Turn taking, which was just seen as such a cognitive behavioral task, you know, taking turns and how we all have to learn to take our turns. But it was like, but where did first turn taking take place? How did we learn that? Okay, so rather than starting on the 5th step of how turn taking takes place, how about if we start at the 1st step and following development? And again, this goes back to our former teachers, you know, Leila Lorenz and Gail Fidler. But Leila Lorenz was really that one to say, we must consider all the aspects of the child. And really, are we? So I hope to do more writing with a partner of some sort. I'll take offers. Anyway, but there's just a lot more to be said. And it really can be integrated into occupational therapy because it's consistent with everything that's always been spoken about. It's a developmental approach. It's thinking about the whole child. It's being holistic. It's a dynamic approach. It's nothing to be memorized. It was to make sure that and participation, understanding the affect of participation is something else that's never spoken about. And yet the affect of desire, so it's really, this is what I've been doing forever, but it's very exciting to really talk about it. That was another benefit of being in the doctoral program, was really looking at the participation was a goal of the World Health Organization. I would have never known that. And so now it's, wow, so then if it's everybody's goal, let's look at the role of affect in participation. How do we help? And if we can help support the affect regulation through our own affect cueing, through our own relationship with our clients, then guess what? We are influencing their ability to participate. Any other questions? Yes, my test. There's a person, not my daughter, yes.
Hi. Question, Mom. It's not really even a question. It's more of just, I'm so proud of you. I am so proud to be here. I don't know what you all are thinking, but it wasn't a random choice for my mother. I'm not going to be ageist here. 62 years old to just decide one day, oh, I'm going to just join the doctoral program. My mom has been working in occupational therapy for way much longer than I've been alive. But let me tell you, she did it with a bachelor's degree. And I think that's what, it was the traditional way that it was, you just got the bachelor's and you were done and that was it. But my mom has continued to love learning, just love learning, period. Whatever it was, if it was occupational therapy, if it was learning about my guinea pig or anything, she just loved to learn about it. So I really urge all of you who are getting your doctorates to not stop, because I can tell all of you are much younger than her, sorry. Don't stop. I know it's the highest degree, but don't stop. Do something amazing. Continue to do something amazing with your time as occupational therapists, so that when you're 62, you can make your daughter proud, or your son proud, or your child, or your guinea pig. So I'm so proud of you, Mom.
Thank you. Oh, so now this is very exciting, but our class, who we're all just meeting for the very first time today, we wanted to present something to Dr. Sullivan and to Dr. Helfrich.
So we just wanted to say a big thank you with some flowers. I think we can all collectively agree that this was a long process, and we definitely could not have done it without your guidance. So thank you very much. We just want to formally recognize you all.
Thank you.
gotta go in sideways.
I see everybody just looking around.
I know we should have this on stage left. Tony, did you get in the middle? To take our picture?
No, I just asked him not to.
Okay, so this ends the fourth annual doctoral capstone presentation sessions. I hope you will join us all next door for the OTD completion ceremony and pinning ceremony, which follows at 5 p.m. across the street at the Sprague Arts Center. Thank you for your attention, and please, if there's anything that you heard today that's inspired you and caused you to have questions for our viewers online or for those in the room today, feel free to contact me. You all have my name and contact information on today's invitation. Thanks again, everyone.
End it. Big red button. All right.